Assalamualaikum warahmatullahi wabarakatuh. Good morning, magandang umaga, ciao an, suprabat, and good luck to all of us. Welcome to the International Seminar of Health Polytechnic of Ministry of Health Jakarta 3, 2022.
Selamat pagi, magandang umaga, ciao an, suprabat. Selamat datang di Seminar Internasional tahun 2022 Politeknik Kesehatan Kemenkes Jakarta 3.
The Honorable Director of Health Polytechnic of Ministry of Health Jakarta 3, Mistress Yupi Supartini, Bachelor of Nursing, Master of Science. The Honorable First Vice Director, Mistress Sri Mulyati, Bachelor of Education, Master of Health. The Honorable Second Vice Director, Mistress Dr. Nimade Riasmini, Bachelor of Nursing, Master of Health, Specialist Community Nursing. The Honorable Third Vice Director, Mr. Bagya Mujianto, Bachelor of Education, Master of Health. The Honorable Head of the Department of Nursing, Mistress Dr. Pramita Iriana, Bachelor of Nursing, Master of Biomedical Science. The Honorable, the speakers who have attended at this international seminar, and the Honorable, all the lecturers and the staff of Nursing Department of Health Polytechnic of Ministry of Health Jakarta 3, and all participants of this seminar. Thank you for attending this event.
Yang terhormat, Direktur Poltekkes Kemenkes Jakarta 3, Ibu Yupi Supartini, SKP MSc. Yang kami hormati, Wakil Direktur 1, Ibu Sri Mulyati, SPD MKes. Yang kami hormati, Wakil Direktur 2, Ibu Dr. Nimade Riasmini, SKP MKes SPK. Yang kami hormati, Wakil Direktur 3, Bapak Bagya Mujianto, SPD MKes. Yang kami hormati, Ketua Jurusan Keperawatan, Ibu Dr. Pramita Iriana, SKP M Biomed. Yang kami hormati, para narasumber yang telah hadir pada acara seminar internasional ini. Dan yang kami hormati, seluruh jajaran manajemen jurusan keperawatan, serta Bapak, Ibu, dan seluruh peserta seminar keperawatan internasional yang berbahagia. Terima kasih atas kehadirannya pada acara seminar internasional pada tanggal 14 Mei tahun 2022.
Before the event starts, let us to introduce ourselves. I'm Jessica and Salwa as Master Ceremony of the International Seminar with the theme First Aid for COVID-19 Patient with Comorbid, which was organized by the Student Association of Nursing Department of Health Polytechnic of Ministry of Health Jakarta 3.
Sebelum acara dimulai, izinkan saya memperkenalkan diri. Saya, Salwa Putri Afifah, dan rekan saya, Jessica Melani Sinaga, sebagai Master of Ceremony pada acara seminar internasional dengan tema First Aid for COVID-19 Patients with Comorbid yang dilaksanakan pada hari ini.
The international seminar was held to commemorate International Nurses Day and was attended by 679 participants who have filled out the registration link. Participants in the international seminar on the Nursing Student Association are from Indonesia, Malaysia, Turkey, India, and China.
Acara seminar internasional ini dilaksanakan dalam rangka memperingati Hari Perawat Internasional dan diikuti oleh 697 peserta yang sudah mendaftar dan berasal dari Indonesia, Malaysia, Turki, India, dan China.
First of all, we would like to remind the participants to fill in the initial attendance form given by the committee via chat Zoom or the YouTube comment column. Initial attendance form is open until 8 o'clock to 9:30 West Indonesia time. All participants must take screenshots while participating in the event to be uploaded on the final attendance form.
Sebelum mulai ke inti acara, mohon izin untuk menyampaikan beberapa hal. Pertama-tama, kami persilakan kepada para peserta untuk melakukan presensi awal melalui link yang ada di chat Zoom. Presensi awal dibuka dari pukul 8.00 hingga pukul 9.30 waktu Indonesia bagian Barat. Seluruh peserta harus melakukan screenshot saat mengikuti acara yang nantinya akan diupload pada form registrasi akhir.
As initial information, we can see the schedule of this seminar. First, opening. Second, we'll be singing Indonesia Raya. Third, we'll be singing the March song of Health Polytechnic of Ministry of Health Jakarta 3. Fourth, we'll be singing March of the PPNI. Fifth, opening remarks from the Director of Health Polytechnic of Ministry of Health Jakarta 3, as well as the opening of the event. 6. Chanting prayers. 7. The seminar will present with 3 speakers from Malaysia, Philippines, and Indonesia, which will be guided by the moderator. 8. Sponsor presentation. 9. Ice-breaking and door prize announcement. And the last is closing.
Hadirin yang berbahagia, izinkan kami menyampaikan susunan acara sebagai berikut. 1. Pembukaan. 2. Menyanyikan lagu Indonesia Raya. 3. Menyanyikan lagu Mars Politeknik Kesehatan Jakarta 3. 4. Menyanyikan lagu Mars PPNI. 5. Sambutan sekaligus pembukaan Direktur Politeknik Kesehatan Jakarta 3. 6. Pembacaan doa. 7. Pemaparan materi oleh 3 narasumber yang berasal dari Malaysia, Filipina, dan Indonesia, yang nantinya akan dipandu oleh moderator. 8. Pemaparan materi sponsor. 9. Ice breaking dan door prize. 10. Penutup.
Next, allow me to convey the participant rules and health protocols during this international seminar. First, participants must register on the registration link listed on the poster before May 14, 2022. Next, the PPNI SKP certificate is only valid for nursing students and nurses.
Selanjutnya, izinkan saya untuk menyampaikan tata tertib peserta dan protokol kesehatan selama seminar internasional ini. 1. Peserta wajib melakukan registrasi pada link registrasi yang tertera di poster sebelum tanggal 14 Mei tahun 2022. 2. Sertifikat SKP PPNI hanya berlaku untuk mahasiswa perawat dan perawat.
Next, participants must write their full name and title correctly on the registration form because they will be printed on the certificate. If there is an error in writing the name, the committee is not responsible for replacing it.
3. Peserta wajib menuliskan nama lengkap dan gelar dengan benar di form registrasi awal dan registrasi pulang, karena akan tercetak dalam sertifikat. Bila terjadi kesalahan penulisan, panitia tidak bertanggung jawab untuk menggantinya.
Next, participants only choose one media provided between Zoom or YouTube channel, the Student Association of Nursing Department. If there is a problem with the media provided by the committee, participants can contact the contact person list. Next, 30 minutes after the opening of the seminar, there will be an initial attendance form, which will be shared via chat Zoom or the YouTube comment column, and participants are expected to fill out the form.
4. Peserta hanya memilih satu media yang disediakan antara Zoom atau YouTube HMJ Keperawatan. Jika terdapat masalah pada media yang disediakan oleh panitia, peserta dapat menghubungi kontak person yang tertera. 5. 30 menit sesudah acara pembukaan seminar akan dilakukan presensi awal yang akan dibagikan melalui chat Zoom atau kolom deskripsi pada YouTube, dan peserta diharapkan mengisi presensi.
Next, all participants are required to wear polite and neat clothes. Next, if participants join via Zoom, all participants must use their full name on the Zoom application as recorded on the registration form. If the committee doesn't recognize the identity of the participant, then the committee has the right to remove the participant from Zoom. During the activity, participants are required to activate the video at the beginning of opening and the end of the event.
6. Seluruh peserta wajib menggunakan pakaian sopan dan rapi. 7. Apabila peserta join melalui Zoom, A. Seluruh peserta wajib menggunakan nama lengkap pada aplikasi Zoom, sesuai dengan yang tercatat pada form registrasi. Jika panitia tidak mengenali identitas peserta, maka panitia berhak mengeluarkan peserta dari Zoom. B. Selama kegiatan berlangsung, peserta wajib mengaktifkan video saat awal pembukaan dan akhir acara. Bila ada satu hal gangguan dari pihak peserta yang membuat gaduh, maka panitia berhak menonaktifkan video dan menonaktifkan suara, serta berhak mengeluarkan peserta.
Next, participants are asked to turn off the microphone while the activity is in progress. Participants are required to take a screenshot when Zooming, and the photo is uploaded to the final attendance form, which will be shared after the event is over.
C. Peserta diminta untuk menonaktifkan mikrofon saat kegiatan sedang berlangsung. D. Peserta wajib mengambil screenshot ketika Zoom, dan foto tersebut akan diupload pada form presensi akhir yang akan dibagikan setelah acara selesai.
Next, if participants join via YouTube live streaming, all participants must use their full name on their YouTube account. Participants who have used the YouTube application are advised not to open the Zoom link for mutual convenience. Participants are required to screenshot the presence of image and activities during live streaming on YouTube. Proof of attendance will be uploaded on the final attendance form, which is open at 11:30 a.m. to 1 p.m. West Indonesia time, and the form will be distributed after the event is over.
8. Apabila peserta join melalui live streaming YouTube, A. Seluruh peserta wajib menggunakan nama lengkap pada akun YouTube-nya. B. Peserta yang telah menggunakan aplikasi YouTube dihimbau untuk tidak membuka link Zoom untuk kenyamanan bersama. C. Peserta wajib screenshot gambar kehadiran saat mengikuti kegiatan live streaming YouTube. D. Bukti hadir akan diupload pada presensi akhir yang akan dibuka pada pukul 11.30 sampai dengan pukul 1.00 waktu Indonesia bagian Barat, dan akan dibagikan setelah acara selesai.
During the seminar, participants are expected to be able to listen to the material without making a fuss and are advised to take notes on the material present by the speakers. Next, if the presentation process is ongoing and there are questions you want to ask, you can ask via chat Zoom or the YouTube comment column with the following question format: full name _ for resource person _ question.
9. Saat webinar berlangsung, peserta diharapkan dapat menyimak materi tanpa membuat kegaduhan dan disarankan untuk mencatat materi yang disampaikan narasumber. 10. Jika pada proses pemaparan sedang berlangsung dan ada pertanyaan yang ingin ditanyakan, maka bisa bertanya melalui link yang ada di kolom chat pada aplikasi YouTube dan Zoom dengan format pertanyaan, nama lengkap, underscore untuk narasumber ke underscore pertanyaan.
Next, it is forbidden to use sentences that contain element of sara. Next, participants fill out the attendance list 3 times as follows. Registration, fill in before May 14, 2022. Attendance form, filling is done in 30 minutes after the opening of the seminar starts and will be sent via chat Zoom or the YouTube comment column. Final attendance form and evaluation, filling is done at the end of the event to confirm the attendance of participants by uploading screenshots as evidence of participating in the activity.
11. Dilarang menggunakan kalimat yang mengandung unsur sara. 12. Peserta melakukan 3 kali pengisian presensi sebagai berikut. A. Registrasi. Pengisian dilakukan sebelum tanggal 14 Mei tahun 2022. B. Presensi awal. Pengisian dilakukan 30 menit sesudah pembukaan seminar acara dimulai dan akan dikirimkan melalui room chat Zoom. C. Presensi akhir dan evaluasi. Pengisian dilakukan di akhir acara untuk mengkonfirmasi kehadiran peserta dengan mengunggah screenshot bukti mengikuti kegiatan.
Next, participants who get certificates are participants who have met the attendance requirements explained in rule number 12. Next, attendance of participants will be monitored by the committee. Next, all the requirements will be sent as evidence of reporting to the DPP PPNI Training Division.
14. Peserta yang mendapat sertifikat adalah peserta yang telah memenuhi syarat kehadiran, seperti yang telah dijelaskan pada Peraturan Nomor 12. 14. Kehadiran peserta akan dipantau oleh panitia. 15. Persyaratan di atas nantinya akan dikirimkan sebagai bukti pelaporan ke Divisi Diklat DPP PPNI.
Next is online seminar health protocols. First, participants are expected to set the distance between the eye and the monitor, which is ideally safe in 50 until 100 centimeters. Second, participants are expected to sit up straight. Third, participants are required to use the virtual background that has been provided by the committee.
Izinkan kami menyampaikan protokol kesehatan seminar online. 1. Peserta diharapkan mengatur jarak antara mata dengan monitor yang aman idealnya adalah 50 hingga 100 cm. 2. Peserta diharapkan duduk dengan tegap. 3. Peserta diwajibkan menggunakan virtual background yang telah disediakan oleh panitia.
Ladies and gentlemen, the seminar participants who we respect, we will sing the national anthem Indonesia Raya, followed by the March of Health Poltekkes of Ministry of Health Jakarta 3, and close with the March of PPNI. Please remain straight and be ready.
Bapak Ibu peserta seminar yang kami hormati, marilah bersama kita mendengarkan lagu Indonesia Raya, dilanjut dengan Mars Poltekkes Kemenkes Jakarta 3, dan ditutup dengan Mars PPNI. Hadirin dimohon untuk duduk tegak.
Indonesia Nasional Indonesia, wujud ikatan profesi perawatan, tempat membina dan mengembangkan kemampuan diri dalam membuktikan keberadaannya. Menapaklah dengan keyakinan lebih pasti, sejajar dalam abdikan diri, bangkit berdiri dan langkahkan kakimu itu, menatap hari esok penuh asa. Wahai perawat Indonesia, bangkitlah dan majulah untuk menolong sekalian yang menderita. Kuatkanlah pribadimu, tingkatkan pengetahuan untuk memberikan asuhan keperawatan. Kita melangkah untuk mengisi pembangunan bangsa negara Indonesia, untuk mengantarkan bangsa menuju sehat semua dengan semangat jiwa Pancasila. Maju perawat, majulah dalam kancah pembangunan, tunjukkanlah pada sekalian orang. Jadilah perawat model kesehatan bangsa kita, jadilah teladan dalam hidup sehat. Bangkitlah perawat seluruh Indonesia dalam mengemban citra profesi, menjunjung tinggi kode etik keperawatan, laksanakan panggilan tugas mulia, tercapai derajat kesehatan seoptimal mungkin bagi warga negara Indonesia. Sebagai bukti kiprahnya mahkota putih suci dalam mendukung pembangunan kesehatan. Dengan organisasi PPNI yang kokoh, padu bersatu serta selaras, perawat Indonesia akan mampu angkat citranya di mata insan dunia.
Next, the opening remark of Director of Health Polytechnic of Ministry of Health Jakarta 3, Mrs. Yupi Supartini, Bachelor of Nursing, Master of Science, who will also open this seminar.
Selanjutnya, sambutan dari Direktur Poltekkes Kemenkes Jakarta 3, Ibu Yupi Supartini, SKPMSC, yang sekaligus akan membuka acara seminar internasional dengan tema First Aid for COVID-19 Patients with Comorbid. Kepada Ibu Yupi Supartini, SKPMSC, dipersilakan.
Oh, gini. Ya. Thank you, the Master of Ceremony. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat pagi, good morning, maganda umaga. The honorable speakers from Malaysia, Miss Tanalik Humi Kanan, RN MSc BSc from Malaysia. And the second speakers, Miss Joylin Liamado Mejila, MAN RN from the Philippines. And the third speakers, Miss Fatriani Escape Nurse dari Indonesia. The honorable guest from Poltekkes Jakarta 3, Vice Director 1, Ibu Sri Mulyati, Vice Director 2, Ibu Nimade Riasmini, Vice Director 3, Bapak Bagja Mujianto, Head of Nursing School, Ketua Jurusan Ibu Pramita Iriana, and Ketua Program Studi untuk professionals Ibu Putu Ekarini, Ketua Program Studi Diplomatry of Nursing Ibu Santun Setiawati, Ketua PPNI Komisariat Poltekkes Jakarta 3 Ibu Nelly Yardes, SKP Ibu Dr. Anda Nelly Yardes, SKP MKes, all the lecturers, all the participants from either from Indonesia and from abroad. I think here's there are some from India, China, Malaysia, and also Turkey. It's around 697 participants who joined this international seminar. Welcome to you all. Join this international seminar, and thank you very much, especially to the honorable speakers who have been available to share the knowledge to the participants. And thank you very much. And also to the participants, thank you for attending this international seminar and support us, support the nursing schools, especially Association of Students of Nursing School Department who run this program. This international seminar has a topic, first aid for COVID-19 patients with comorbid and other high risk. It is very good topic choose by the committee. So I really appreciate to all the committee on behalf of the Association of Student Association of Nursing Department from at Polytechnic of Jakarta 3 and all the lecturers who support them. And this seminar, this international seminar, is also special event in terms of the celebrating International Nurses Day 2022 with the theme in Indonesia, we have a voice to lead, invest in nursing and respect rights to secure global health. This is the theme of Indonesia International Nurses Day, chosen by the Association of Nursing Indonesia, National Nursing in Indonesia. This topic, really, we have passed around 2 years. We faced the COVID-19 pandemic and very much problem that we have already faced, and also we hand in hand to solve this problem among us, nurses, lecturers, students, to support the government how to combat, how to face this pandemic, COVID-19. But now we have several problems regarding the impact of the COVID-19 pandemic. However, we have already gain several benefits also from this pandemic COVID-19, especially in higher education institution, such as Health Polytechnic in Indonesia. We have some benefits, especially in the teaching learning process. We have gained some new methods, new technology, how to run the teaching learning process during pandemic by using the high technology, by using the digital technology. This is very valuable for us. I believe also in the hospital, our colleagues in the hospital also gain some benefits, could learn and gain some benefits from the experience facing the COVID-19 pandemic. All the participants in this international seminar, we have 3 speakers who will share their knowledge, their important knowledge to you all about the management of hypertension and diabetes mellitus as comorbid COVID-19. Will be given by the first speakers. Then the second speakers will given you the knowledge and experience how to manage, about management of COVID-19 patients with comorbid diseases in the hospital. And the last but not least, this is very important because this is happen in our country, in Indonesia. Regulation and identification, the application emergency installation trials in the era of COVID-19 pandemic will be given by Ibu Patriani, escape nurse from Rumah Sakit Cipto Mangunkusumo. So please pay attention, and again, a lot of knowledge and experience from all the speakers. So last but not least, finally, we hope that all the participants could gain knowledge and broaden the perspective on that content will be given by the speakers. So good luck, have a good seminar, have a good international seminar, and stay healthy and safety. Let's begin and open together this international seminar by expressing our prayer to God. Bismillahirrahmanirrahim. Semoga Allah Subhanahu wa Ta'ala meridhoi dan memberkati kegiatan ini. May God bless us always and forever. Terima kasih. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you to Mr. Yupi Supartini for the greeting. Before we continue to the main event, let's pray for a moment, which will be led by Bismil Hanifah.
Sebelum kita melanjutkan acara inti pada hari ini, mari kita sama-sama membaca doa yang akan dipimpin oleh Saudari Bismil Hanifah. Kepada Saudari Bismil Hanifah, dipersilakan.
Assalamualaikum warahmatullahi wabarakatuh. Allow me to lead prayers in an Islamic way. Ladies and gentlemen, please adjust according to the respective belief. A'udzu billahi minasyaitonir rajim. Bismillahirrahmanirrahim. Hamdan syakirin, hamdan na'imin, hamdan yu'afi ni'amahu wa yukafi mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhika karimi wa azimi sultan. O Allah, our God, all praise be to you, preserver of the universe. All praise for the gift and pleasure that you bestow on us. Praise be to your majesty. All praise to your glory and power. Allahumma salli wa sallim ala sayyidina Muhammadin wa ala alihi wa sahbihi ajma'in. Ashhadu an la ilaha illallah wa ashhadu anna Muhammadar Rasulullah. Ya Malikul Quddus, we glorify your name because you alone are our God. To you we prostrate, only to you we give thanks, and only to you we pray. Ya Rahman, Ya Rahim, we worship, and only to you we ask for help. Ya Rabbana, today we are gathered here for the 2022 International Seminar. So, make our event a success, bless it, and fill this meeting with goodness from beginning to end. O Allah, who knows the unseen, guide us with your guidance. Bless us, our future guests tonight, and make our hearts always happy with you. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. O Allah, give us patience and make our affairs easy. Allahumma arina al-haqqa haqqa warzuqna ittiba'ah wa arina al-batila batila warzuqna tinabah. O Allah, show us that what is right and give us the strength and ability to carry it out. And show us that what is wrong and give us the strength and ability to Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Ya Allah, our God, bestow upon us happiness in this world and in the hereafter, and save us from the torment of your hellfire. Wassallu ala Muhammadin wa ala alihi wa sahbihi ajma'in. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Ms. Hanifa, who has led the prayer today. Next is the main session of this event, the seminar, namely First Aid for COVID-19 Patient with Comorbid. And the first session will present first speaker from Malaysia. The delivery of all material, question and answer session with the speaker will be guided by Mistress Rita Ismail, Bachelor of Nursing, Master of Public Health, MTDHE, PhD. She is a lecturer in the Department of Nursing Health, Poltekkes of Ministry of Health Jakarta 3.
Hadirin peserta yang saya hormati, selanjutnya kita akan masuk ke inti acara Seminar Internasional dengan tema First Aid for COVID-19 Patients with Comorbid. Pemaparan materi oleh narasumber pertama yang berasal dari Malaysia. Untuk pemaparan materi dan sesi tanya jawab akan dipandu oleh moderator kita, yaitu Ibu Rita Ismail, SKP MKM, MTDHI, PhD. Beliau adalah dosen di Jurusan Keperawatan Poltekkes Kemenkes Jakarta 3. Berikut adalah CV beliau. Okay, this is Mistress Rita profile. Her name is Rita Ismail, SKP MKM, MTDHI, PhD. And her address is in Poltekkes Kemenkes Jakarta 3, Ministry of Health, Arteri George Street, Jatiwarna, Pondok Melati, Bekasi, West Java, Indonesia. This is her email, ismail.uw10@gmail.com. From 1996 until 2000, She graduated from Faculty of Nursing University Indonesia and received her Bachelor of Nursing title. And from 2003 and 2005, she graduated from Faculty of Public Health University in Indonesia. From 2008 until 2009, she graduated from Ewha Women's University, Seoul, South Korea, and received her title Master of Technology and Development, Health and Environment, Nursing Science. From 2010 until 2014, she graduated from School of Nursing, University of Washington, and received her Doctor of Philosophy title. From 2012 until 2014, she graduated from Department of Global Health, University of Washington. And from 2011 until 2014, she graduated from Department of Global Health, University of Washington.
Next, she has published several scientific journals and the latest journal entitled Classifying Stigma Experience of Women Living HIV in Indonesia through the Social Ecological Model in 2022. In addition, she also published several books, and the last one is entitled Pendekatan Riset Kualitatif Kepatuhan Minum Obat Antiretroviral Terapi pada in 2021. Next, Ms. Rosrita Ismail is also active in several professional experience, and now she's a lecturer of Maternity Nursing Department, Health Polytechnic Jakarta 3, Republik Indonesia. Ms. Rosrita Ismail also do a talks, conference, and workshop. And the last one entitled Keselamatan Pasien dalam Tata Pelayanan Dasar dan Kritis dalam Keperawatan on March 19, 2017, Samarinda, Indonesia. Okay, to Ms. Rosrita Ismail, you may guide this session.
Kepada Ibu Rita Ismail, SKP MKM MTD HI PhD, dipersilakan untuk memandu sesi pertama kita.
Thank you very much for the Master of Ceremony, Salwa Putri Afifa and Jessica Meliani Sigata. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. It's an honor for me to have you in the international seminar about the first aid for COVID-19 patients with comorbid. My name is Rita Ismail. I'm a lecturer at the School of Nursing, Health Poltekkes Jakarta 3, and I'm so delighted to be in here as the moderator for this seminar. And on behalf of the committee, I would like to welcome you all to this seminar. For this session, we are going to have two speakers who are going to share their experiences about first aid for COVID-19 patients with comorbid. The first speaker is from Malaysia, and her name is Tanalekumi Kanan, RN, MSc, BSc, and the second one is Joylin Lamado Mejila, MAN, RN from the Philippines. And before we start, we are going to inform that for each speaker, they are going to have time 30 minutes for presenting their presentations and 10 minutes for question and answer. And before we start, I'm going to read the curriculum vitae or the first speaker, Mrs. Tanalekumi Kanan, RN, MSc, BSN. And she's going to share her presentation about management of hypertension and diabetes mellitus as comorbid. As I mentioned before in the beginning that she's from Malaysia, but right now she's working in the Saudi Arabia at the main operating room King Abdulaziz Medical City, Ministry of National Guard Health Affairs, Riyadh, Saudi Arabia. And you can see her email address and phone number that you can contact if you have any interest or you have something to ask in the future. Next. And for her professional summary, she's a flexible operating room registered nurse, experienced in working under intense pressure and providing accurate and responsive care. She also proficient in patient analysis, care plan development, and implementation, and emergency operating room leading. She demonstrated success in implementing process and performance improvement initiatives to advance patient care and hospital goal. Furthermore, and for next, please. For her educational qualification, she graduated from College of Nursing Penang, Malaysia diploma in 2003, and she also completed her Bachelor of Science in Nursing in September 2008 at the University of Northumbria. And also for her master degree, she earned it from the Sun University, and she had it in October 2016. Next, please. This is her professional experience. So Ms. Kanan provides direct patient care utilizing the nursing process within established hospital, divisional, and unit-specific policies and procedure, standards, and policies. She also coordinates and evaluates patient care and safety through collaborative effort with healthcare providers and professionals in accordance with the nursing process and the standard of care and practice. Next, please. For her summary of skill, including policy and procedures and excellent clinical and theater nursing care skill, ability to use evidence-based practice in patient care, and contributing to team success. Next. For organizations, she is proactively prioritizing the needs and effectively manage resource and time, and also knowledge of surgical instruments used in operating procedures. She also demonstrates ability to critically evaluate and appropriately act upon the information. Skills in calmly patient before the surgery, and this is really important one. And the last but not least is she's good in communication, excellent interpersonal and coordination skills. Next, please. So without further ado, I would like to welcome our speaker, Ms. Tanalekumi Kanan, RN MSc BSN. To Ms. Tanalekumi Kanan, please. So the time is yours.
Thank you so much.
You're very welcome. So before we start, I'm just afraid that I pronounce your name incorrectly. Is it correct if I say Miss Tanalekuni Kanan?
It's at Tana Lechumi Kanan.
Tanalekuni Kanan. Okay,
Yes.
Thank you so much.
Thank you. Okay, a very good morning, everyone, to committee member, moderator, colleagues, ladies and gentlemen. Thank you for inviting me for this conference and for giving me the opportunity to talk about management of hypertension and diabetic mellitus as comorbid COVID-19. I would like to share my slide. Can you guys see my slide?
Yes, we can see the slide now.
Okay, that's great. Okay, my topic today is management of hypertension and diabetes mellitus as comorbid COVID-19. As moderator introduced that currently I'm working in Saudi Arabia, that means my study will be related in Saudi Arabia. Okay, in early December 2019, a cluster of acute pneumonia of unknown etiology was identified in Wuhan, China. The pathogen was identified as a new RNA virus from beta coronavirus family and was named severe acute respiratory syndrome coronavirus 2. From there, it spread rapidly and threatened many different countries in the world, resulting in morbidity and mortality. The World Health Organization, WHO, declared coronavirus disease 2019 a public health emergency of international concern. In the Kingdom of Saudi Arabia, the first COVID-19 case was declared on March 2, 2020, and most of the confirmed cases were due to returning travelers and their immediate contact. Among the Gulf Cooperation Council countries, Saudi Arabia holds the record with the highest number of cases, that is 340,000, and death is more than 5,200. In historical decision, Saudi Arabia has suspended Umrah and all religious visits to the country in an attempt to prevent and delay the spread of COVID-19 in Saudi Arabia. At the time, many observational studies have emerged from different countries in identifying risk factor and clinical characteristic association with COVID-19 severity. A consistent risk factor associated with COVID-19 mortality is old age, which has been singled out by both the World Health Organization and the Center for Disease and Control as the most vulnerable population from COVID-19. The disease also can progress rapidly to acute respiratory distress syndrome in other risk factors associated with old age, such as diabetes mellitus, hypertension, and obesity, making the population potentially more susceptible for worse COVID-19 outcome. There is a similar study conducted in the USA. As of March 28, 2020, USAF reported 122,653 COVID-19 cases to CDC, including 7,162, which is 5.8% for whom data on underlying health condition and other known risk factors for severe outcome from respiratory infection were reported. Among these 7,162 cases, 2,692, which is 37.6%, patient had one or more underlying health condition risk factor. The percentage of COVID-19 patients with at least one underlying health condition or risk factor was higher among those required intensive care unit admission, which is 358 out of 457, that is 78%, and those requiring hospitalization without ICU admission was 732 of 1,037, that is 71%. Then that among those who were not hospitalized, which is 1,388 out of 5,143, that is 27%. This is the high risk group, which I mentioned earlier. The most commonly reported condition was diabetes mellitus, which is 784, which is a 10.9%, and chronic lung disease 656, which is 9.2%, and cardiovascular disease was 647, which is 9.0%. Among hospitalized COVID-19 patients is much more than non-hospitalized COVID-19 patients. Hypertension, obesity, and diabetes are closely linked to each other, and these comorbidities are associated with an elevated risk of recurrent infection due to underlying impairment in the host defense system. As an efficient and integrated immune defense system is necessary for the body response to infection. A compromised immune response makes the host more vulnerable to infection and related severe complications. These preliminary findings suggest that in the USA, persons with underlying health condition or other recognized risk factor for severe outcome from respiratory infection appear to be higher risk for severe disease from COVID-19 than a person without this condition. For instance, a study conducted in Wuhan, China, that analyzed 26 fatal cases demonstrated that diabetic was found in 42.3% of fatality due to COVID-19 and was the second most common disease found in COVID-19 patients after hypertension. In addition, the Chinese Center for Disease Control and Prevention published a report on 72,314 cases of COVID-19 that reveal an increased rate of fatality in patients with diabetes, which is 7.3% when compared with overall mortality of 2.3%. Likewise, a prospective cohort study conducted on COVID-19 patients from New York City reported that diabetes was prevalent among patients admitted to the hospital, with 34% of them having diabetes. Another study by U.S. Department of Health Human Service Center for Disease Control Prevention concluded that the hospitalization rate of COVID-19 patients was highest in those 65 years old and above, which is 13.8%, and among adult patients, 89.3% had one or more underlying conditions such as hypertension, 49.7%, and chronic vascular disease was 27.8%. COVID-19 can be transmitted from person to direct transmission, example, cough, sneeze, respiratory droplet, contact spread, like contact with patient material or human fluid, and contaminated surfaces, example, metal or glass surfaces contaminated with the viruses. As I discussed earlier, this is the mode of transmission of the COVID positive. The highly contagious nature of the virus and its propensity to disperse from person to person via respiratory droplet mean that the only option to curb its spread was to impose containment measures such as enforcing nationwide or local lockdown, travel restriction, social distancing, school shutdown, and cancellation of in-person outpatient visit and reduced hospital clinic schedule. Patients with severe comorbidities such as diabetes and hypertension had experienced a myriad of challenges due to the pandemic. Patients with diabetes and hypertension and COVID-19 exhibit high risk for developing serious complications, including respiratory tract infection, multi-organ failure, and finally death. It is believed that multiple factors that impair immune response, in particular, are responsible for the heightened risk in COVID-19 infection among patients with diabetes. Besides, the high glucose level are noted to damage the defense mechanism of the immune system in such patients and trigger a few diabetes-related problems, including nerve damage. The impaired blood flow escalate the susceptibility of the patient to infection. COVID-19 patient with coexisting hypertension, high blood pressure was independently associated with hospitalization, mortality, and heart failure. Also, many patients with type 2 diabetes mellitus are overweight, and obesity also been identified as another risk factor for those patients with severe COVID-19 infection necessitating hospitalization. From a few research work done in Saudi Arabia, diabetes has been identified as one of the predominant risk factors for COVID-19 as presented in Table 1. I will go through this. The result from a multi-center retrospective cross-sectional study performed from March 1st, 2020 to 31st, 2020 across all parts of the country revealed a high percentage of diabetes among COVID-19 patients. Reported comorbidities 85 as diabetes. The second study from a retrospective study in March 2020 done on 648 COVID-19 patients in healthcare facility across all parts of Saudi Arabia, 73, which is 11.3%, COVID-19 patients were found to have diabetes. In another retrospective, a single center study was performed at Al Noor Specialist Hospital, Mecca, using 150 COVID-19 patients from March 12 to 31st of 2020. 26% of the patients were reported to have diabetes among the cases hospitalized. In yet another study done from March 1st, 2020 to April 5th, 2020 on 82 adult COVID-19 patients, in total 26% of them were identified as having diabetes. This one of the study performed at King Saud University Medical City in Riyadh from March 22, 2020 on May 31st, 2020 using 99 COVID-19 patients undergoing hospitalization found diabetes to be the most frequent, which is 31.3% comorbidity in this group. Another study at Prince Mohammed bin Abdulaziz Hospital in Riyadh, a descriptive cross-sectional study, was performed from March 1st, 2020 to May 2020 using 458 COVID-19 patients, where 62, which is 13.6% patients were found to have diabetes. At King Abdullah Hospital in Bisha Province, Saudi Arabia, another retrospective study was done from March 20 to June 30, 2020, where 37, which is 27% of 137 patients revealed diabetes. In King Saud Medical City, Riyadh, Saudi Arabia, 768 COVID-19 patients were used in a record-based case series study from March 23, 2020 to June 15, 2020, where 96.3% were identified with presence of more than one comorbidity, of which the most frequent was diabetes mellitus, which is 46.4%. Another study, this is from a same hospital, another study from King Saud Medical City, Riyadh, Saudi Arabia, conducted from March 1st, 2020 to June 30, 2020, found diabetes to be the most frequent, which is 37.3% comorbidities among COVID-19 patients. Again, we go back. A descriptive cross-sectional study performed at a 5 tertiary care hospital in Riyadh, Saudi Arabia from April 22, 2020 to May 21st, 2020, using 401 COVID-19 patients, 41, which is a 10% were reported to have diabetes. Later, at Prince Sultan Military Medical City, Riyadh, a large retrospective 3-month study was done on a total 7,260 COVID-19 patients from May 2020 to July 2020. The result reported 920, which is 12.6%, including patients isolated at home as having type 2 diabetes. Further, it was clear that the older individual with diabetes and those having higher HbA1c level, as well as patients with comorbidities like hypertension, cardiovascular disease, cerebrovascular disease, chronic pulmonary disease, chronic kidney disease, malignancy, and those requiring insulin treatment had a greater likelihood of requiring hospitalization. At King Saud University Medical City and King Khalid University Hospital, Riyadh, Saudi Arabia, a retrospective study performed on 439 patients showed that diabetic prevalence was 68.3%, a result drawn from available record and newly diagnosed cases. The study also revealed that individuals with diabetes showed a much higher death rate, which is a 20.5% versus 12.3%, and lower survival time than patients without diabetes. Further, another study done with 300 adult patients carrying confirmed COVID-19 infection and hospitalized at King Salman Hospital from May 1st to July 31st, 2020, showed type 2 diabetes as the most typical comorbidity is 45.7% of those affected with COVID-19 disease. A study conducted among 566 patients at Security Forces Hospital in Riyadh, Saudi Arabia between March 15 and June 30, 2020 showed that the most common comorbidity was diabetes, which is 123 out of 566, that is 21.8%. It is noteworthy that the Ministry of Health in Saudi Arabia confirmed that approximately 50% of the COVID-related death among the critical cases present in an ICU were from among patients experiencing chronic disease such as diabetes. A recently published stated that diabetes significantly more prevalent in hospitalized patients than in non-hospitalized patients, and patients with diabetes had a 52.1% higher risk of hospitalization than a patient without diabetes. There is a depth of study regarding newly diagnosed diabetes among patients with COVID-19 in Saudi Arabia. Emerging evidence show that newly diagnosed diabetes is often detected in severe or critical COVID-19 patients. In a case series from Saudi Arabia stated that out of 5 reported COVID-19 cases, 3 were known to have pre-existing diabetes and 2 with newly diagnosed diabetes based on the significantly elevated HbA1c level during hospital admission. Reports have revealed that newly identified diabetes may confer a higher risk for poor prognosis of COVID-19 and had the higher risk of mortality than people without diabetes and pre-existing diabetes. These findings from the literature indicated the need to provide comprehensive and holistic care to patients with diabetic and hypertension, which might be challenging during the COVID-19 pandemic due to limited in-person care at outpatient clinic and patient fear of exposure risk. Furthermore, care of patient with diabetic or hypertension might be compromised because of the diversion of financial, material, and human resources towards COVID-19. Some of the primary challenges for diabetes care during the pandemic could be limited access to healthcare, health education, routine laboratory investigation, and medication. This could have worsened due to the COVID-19 lockdown. These restriction measures have also affected the routine care of the patient with diabetes and hypertension, which in turn might result in uncontrolled glycemia or blood pressure or worsening status of comorbid disease in patients with diabetic and hypertension, mainly among those with uncontrolled diabetes and high blood pressure. However, most of health sector in different countries have implemented alternative and effective strategy to overcome this challenge and to provide timely and effective care to such patients. On December 17, 2020, a vaccination campaign was launched against COVID-19 by the Minister of Health. The MOH has stressed that this vaccine is one of the most important stages in dealing with this pandemic. The Saudi Society of Diabetes provided clinical care guidelines for diabetes during the COVID-19 pandemic that covered glycemic target, a management plan for different types of diabetes, the therapeutic principle of glucose management plan according to the COVID-19 severity, glucose management of patients treated with glucocorticoid, and glucose management of children and adolescents with COVID-19. In addition, the MOH of Saudi Arabia has provided a guideline for diabetes to be a reference during COVID-19 pandemic, which comprises measures to avoid the COVID-19 disease. Moreover, the Ministry of Health of Saudi Arabia provided a general summary of COVID-19 management and treatment guidelines for patients with different comorbidities, including diabetic and hypertension. Furthermore, the Saudi National Diabetes Center in Saudi Health Council prepared the guidance aiming the specialists of healthcare in the management of diabetes during the COVID-19 pandemic, which comprised the recommendation of the emergency room visit, outpatient management of diabetes to control COVID-19, guideline of admission and inpatient management of COVID-19 for people with diabetes. The Saudi Ministry of Health has implemented several informatic tools to deliver public health information for individual and community. The private sector and government of Saudi Arabia developed and launched about 19 apps and platforms that help public health function and provide healthcare services. Now we will go to a recommendation for the patient with comorbid for COVID-19. It is suggested that a well-planned and structured education program should be commenced to upsurge the awareness and contribute to better practice among people with diabetes and hypertension. B. Patients with diabetes or hypertension need to adopt the Ministry of Health instruction to prevent being infected. However, patients developing symptoms of COVID-19 disease should immediately inform healthcare service to find out the necessities for assessment of severity, diagnostic evaluation, isolation, and hospitalization. For the reason that there is higher risk of adverse effect, patients with diabetes or hypertension should be preferentially managed in a hospital or setting where close monitoring of disease progression is possible. C. Patients who are infected COVID-19 are recommended to follow guidance for home stay procedure for COVID-19. The guideline provides several tips for home isolation patients, such as stay calm, psychologically stable, and strengthening immunity. B. For patients who are managed at home, regular telephone contact with healthcare services and follow-up is essential to recognizing deterioration in glycemic control, hyperglycemic emergency, or clinical status deterioration. E. During the COVID-19 pandemic, if patients with diabetes maintain good glycemic control, which will be critical in maintaining low vulnerability and protection from the severe effect of COVID-19. The most important fundamental principle of care for mild outpatient cases are regular glucose monitoring, a patient-tailored therapeutic approach, and following the medical recommendation regarding lifestyle measure and drug treatment. G. For critically ill hospitalized patients with COVID-19, tight monitoring of glucose or blood pressure, fluid, electrolyte, pH, and blood ketones is paramount to improving the outcome. Hence, for people with diabetes and COVID-19, regular glucose monitoring, a health diet, adequate hydration, and dose titration of glucose-lowering medication in license with healthcare providers should be prioritized. In patients with type 1 diabetes with COVID-19 and hyperglycemia, it is essential to monitor the blood glucose and ketone level, maintain hydration, and continue insulin therapy. People with diabetes who have not yet been infected with the COVID-19 should improve their metabolic control as necessary as means of primary prevention of COVID-19 disease. Further, diabetes patients should also be encouraged to follow general advice from the WHO, IDF, Center for Disease Control and Prevention, American Diabetes Association, and Saudi Ministry of Health guidelines about hand washing and physical distancing. J. It is well demonstrated that a large number of patients with type 2 diabetes have other components of the metabolic syndrome, including but not limited to hypertension and dyslipidemia. Therefore, continuation with an appropriate antihypertensive and lipid-lowering regime in all patients with diabetes is essential. Next point. A high number of patients with type 2 diabetes are living with the condition of overweight or obesity. Several studies stated that obesity is an independent risk factor for the vulnerability of COVID-19. The severity of COVID-19 and substantially increased the risk of hospital admission and fatality. Hence, in the current pandemic, obese people with diabetes should be included as one of the clinically vulnerable groups, particularly patients having morbid obesity, which is BMI more than 40 kg. Next point. During the hospital admission, diabetes patients with COVID-19 have a wavering level of insulin necessity due to factors such as concomitant medication and altering pathophysiologic condition. Therefore, patients with a type 1 diabetes, type 2 diabetes managed with insulin, or type 2 diabetes not managed at home with insulin who have elevated blood sugar in the hospital should have scheduled insulin while inpatient. Although it is essential to ensure that patients receive regular glucose monitoring while on insulin therapy and control their blood glucose at home to prevent severe COVID-19 infection, medication use is also considered in the outpatient setting. Next point. A study from Saudi Arabia stated the pandemic had caused a disruption in the diagnosis of diabetes, which apparently increased the frequency of diabetic ketoacidosis and severity, which highlights that healthcare access to undiagnosed and diagnosed people with diabetes should continue in the standard of level of care during a pandemic.
Excuse me, Mrs. Kenneth. I would
Yes.
like to remind that you have 5 minutes left for presentations.
Sure.
And
thank you.
also, would you mind to turn on your camera because we cannot see your camera on right now. Thank you.
To the last point, the healthcare workers should be considered and conscious of the application of the clinical program and clinical education proposed to increase compliance with the ADA 2021 guideline for standard of care. As per ADA standard of care, diabetic center health specialists must be educated to document appropriately clinical practice procedure. Okay, what practical advice should we give to the majority of people with type 2 diabetes, hypertension? People with diabetes should be reminded that diabetes or hypertension increase risk of many infections and that may include COVID-19. Essential self-care behavior for people suffering from diabetes or hypertension to maintaining good glucose control and blood pressure, that healthy eating, physical activity, healthy coping skill, self-monitoring of blood glucose, compliance to the prescribed medication, good problem-solving skill, and risk reduction behavior are important. Current UK advice is to continue usual glucose-lowering drug and maintain our blood pressure and aim to optimize glucose control and blood pressure. Antihypertensive, including ACEs and ARBs, and lipid-lowering drugs should be also continued. Management of confirmed COVID-19 cases, the goal is to reduce morbidity and mortality and minimize transmission, especially hand hygienic, respiratory hygiene, social distancing, mandatory mask, and vaccination regime. Triaging patient and early identification of severe cases that may need hospital or ICU admission is important in morbidity and mortality. Prevent transmission of coronavirus, contact tracing, and patient education on cough hygienic and IPC at home. This is the way to prevent as a hand hygienic, respiratory hygienic, social distancing, and high risk group as we discussed earlier. Conclusion, clinical guidelines for COVID-19 are changing rapidly. Our contribution is essential to the fight against COVID-19. Our most important contribution is adherence of WHO guidelines. And all the study references are given here. Final message, together we shall defeat COVID-19, and thank you so much.
Thank you very much for Ms. Tanali Kumikanan for the inspiring presentation about how we deal with patients with comorbid hypertension and diabetes mellitus for a patient with COVID-19. And now we are going to have questions and answer sessions. So if you or the participant have any question regarding the topic that we are having right now, you can write it down on the chat box and we are going to read the questions that will be shared by the committee. Sure. So do we have already questions from the participants committee? So while waiting for the questions, I was wondering about the management of patient with hypertension, diabetes mellitus in Saudi Arabia. Is there any different that what they have done in Saudi Arabia and other countries, for example, in China, in dealing with patients with comorbid?
As I mentioned earlier, there was, as I mentioned in the, like I showed, one second.
Because you said it's changing rapidly for the guidelines that how to deal with patients with comorbid. I was wondering, is there any different that Saudi Arabia country and other countries have done with the patient like this?
No, whenever when there is a lockdown, when there is no lockdown also, but the healthcare facilities was given by have a close contact with patient with comorbid, especially they are least because patient couldn't come to hospital to get their medication. They will have a one committee people, healthcare professional who call the patient to make sure they have a stock for 1 week and maintaining their blood glucose. Then they're giving the health support, especially the psychological support, because majority of patient when they had the lockdown, they get psychologically affected, which is a very important in Saudi Arabia. They look at it and give a support, emotional support to patient, because whenever they stuck in home, especially when lockdown time, when the psychological support are very important for patient who have comorbidity, because if there is a no follow-up from the healthcare practitioner, they may start to eat food uncontrolled, diabetic, they're not managing. In that sense, in Saudi Arabia, they closely follow up the patients and make sure they have enough stock of medication and enough food, and especially healthy food for the citizen to have peaceful lifestyle, to not feel anxiety attack when there is a lockdown, when they couldn't communicate with the loved one. And they encouraged people to social distance, but not social isolation. In that sense, Saudi Arabia give a very well support to patients to have a close relation with healthcare practitioner to make sure they have their medication well.
I see. Thank you very much for the answer. And would you mind to stop the share screen, because the committee will share the screen about the questions? Thank you.
Thank you.
Anitya bisa bagi ininya, share screen-nya. We have several questions already, so I'm going to read the questions once we can see the screen. So while waiting, I was wondering what time in Saudi Arabia right now, because we have 10 o'clock in Indonesia, and what time is in Saudi Arabia?
It's exactly 6 a.m.
AM. Okay, so it's 2 hours behind. So this is the question that we have for you. The first one is from Ada Irma from Poltekkes Kesehatan Jakarta 3. And her question is, blood pressure is one of the requirements for getting the COVID-19 vaccination. Meanwhile, in people with hypertension, the blood pressure is above normal. Then what is the best way to prevent transmission for the people with hypertension? Because they have restriction for the blood pressure, they cannot get the vaccination, but they also need to be prevented from the transmission.
Okay, thank you for the question. Okay, for hypertension, the most important to maintain the blood pressure during COVID-19 pandemic situation, it's very important. And also, it is very important to a healthcare professional to give health education to patients, especially encourage them to have healthy eating, physical activity, healthy coping skill, self-monitoring of the blood pressure, compliance to the prescribed medication, good problem solving, and risk reduction behavior. In that sense, they need to have a close relation with the family member or healthcare professional to maintain, because most of the time they couldn't control the blood pressure, could be anxiety attack, stress, people lost their job. These all can contributing factor. That means a social support is very important to patient with hypertension. That's why, as I said earlier, social distancing is different than social isolation. As a healthcare professional, we are there to support and give them a proper healthcare education, because every now and then the guidelines are changing. Thank you.
So I see. So even the patient cannot get vaccination, but they have to stay and apply healthy lifestyle and still contacted with the healthcare
Yes.
providers, and also getting support from their family and healthcare providers. Okay, thank you. And now we are going to go to the second question from Surya Putri. She's from Poltekkes Kemenkes Jakarta 3. And the question is the COVID-19 vaccination safe for people with diabetes mellitus? And will there be special side effects after the COVID-19 vaccination for people with diabetes mellitus?
Thank you so much for the question. As a lot of research are coming out about the vaccination with patient with comorbid, but as my observation and from our hospital, it is safe for every individual with or without a comorbidity to have a vaccination, because it is a protection. The severity of COVID-19 is lesser than patient without having a vaccination. It is very clearly we could see the effect of a COVID-19 after the vaccination is much lesser than without a vaccination. That means it is safe for with a healthcare guideline and with a professional like doctors. They are make sure that a patient to have vaccination, and they will do a follow-up. If we will give a health education to patient with comorbidity, if they have any kind of symptom, to call a particular number which we can provide them immediate service. But so far, it is a very safe for patient who have a diabetic or hypertension, especially diabetic, to have a vaccination, which will be very safe for them. Thank you.
Okay, so I can conclude it's better if get vaccinated, even though it has several side effects, but it will make the patient will have a better or less complications if they do not get any vaccination. And now we have the last one. It's from Rindi Rohdiana. The question is how to reduce the high risk of death in COVID-19 sufferers with hypertension and diabetes mellitus.
Thank you for the question. As we discussed earlier, the goal is to reduce morbidity and mortality and minimizing transmission. That means hand hygienic, mandatory of wearing mask, vaccination, and a good diet, especially good mental health, are all important factor to reduce the transmission. When the reduced transmission can reduce the morbidity and mortality rate. Thank you.
Thank you. So the most important is reduce the transmission first.
Yeah.
Okay, thank you. Is there any questions from the chat box or from the question link, the committee, or that's enough? I think that's all the question for you. Thank you very much for the answer, and that's really helpful for us to understand about how to deal with hypertension and diabetes mellitus with patients with comorbid COVID-19. And before we end this session, I'm going to conclude that in dealing with patients with hypertension and diabetes mellitus, we have to really pay attention by controlling blood glucose and blood pressure for the patients, because they are going to have more severe complication and poor prognosis compared to the patient without any this comorbid patient. And for this one, the healthcare providers should implement alternative and effective strategies in dealing with this problem. And we are going to have handed the certificate and will be given by the Secretary of School of Nursing, Health Poltekkes Jakarta 3, Ibu or Miss Indriana Rahmawati. To Miss Indriana, please. You can unmute your microphone first.
Baru deh. Ya, oke, thank you, baru berhasil. Thank you, Miss Rita, and thank you to Miss Tanalechuni Kanan. So on behalf of the Director of Poltekkes Kemenkes Jakarta 3, I will give the certificate, and this is my highest appreciation for you, Miss Tanalechumi, and thank you so much for your participation and your support as a speaker in this international seminar. And may you always be healthy in the coming year. Please receive the certificate.
Thank you so much. I sincerely congratulate your team on the success of conference, which was well organized, well balanced, and had a very topical agenda. I wish you and your team further achievement and hope for continued cooperation. Thank you so much. I really appreciate it.
Thank you so
You're
much.
very welcome. Yeah. Thank you, Ms. Telekumikanan. And I want to say something in Arabic language, I think. So can I say, Shukron ya Habibti? Is that correct? I learned it from my Arabic friends. Thank you very much for your time. And we would like to have you in here until the end. But if you have any other things to do, it's okay for us if you leave after this session. Thank you very much. I think I'm going to have the second speaker for now. So now we are going to have the second speaker. The second speaker is Miss Joylin Lamado Mejila MAN, RN, and she will present her topic about management of COVID-19 patient with comorbid disease in hospital. And before we start, I'm going to read her curriculum vitae. Miss Mejila was born in 1971 in Manila, and she's married right now, and now she's also living in the Philippines. We can see her contact address and also her email address in here. Next. So for her education, she's Executive Master on Business Administration at Centro Escolar University Manila in December 2020. And then she's also right now a student for Doctor of Philosophy major in Educational Management at De La Salle University. And in 2000, she graduated for Master of Art in Nursing in Lungso and Manila, and her thesis about quality of life after kidney transplantation. And she earned her BSN at the same university and Lungso at Manila in 1992. Next, for her work experiences, she's right now is assistant to the Dean for Instructions at Central Escolar University from 2008 until now, and also teaching maternal and child nursing, medical surgical nursing, and research at Central Escolar University. And until 2008, she was an administrative assistant for BSN program at Centro Escolar University. And from April 2002 until March 2005, she was the coordinator for clinical area for BSN level 3 at Centro Escolar University. And also from June 2000 until now, she is a lecturer and clinical instructor also at Centro Escolar University. Next, please. For publication, Ms. Mejila published several publications, for example, kidney transplantation and analysis of their quality of life that was published in AP Lambert Academy Publishing, and also she has published for the title Level of Awareness and Compliance in Triad Management and among adolescents diagnosed with diabetes mellitus, basis for development of health teaching material. Next. So this is also several of her publication in 2016 and also in 2019. Next, please. For her special training, she was trained for diabetes nurse educator and also internal quality auditor and outcome-based education and module developer for online flexible learning, supervise faculty in the implementation OBE and online flexible learning. Next, please. And this is her organization and association. She is the member of Philippines Nurses Association, also for Philippine Nurses Association as a chair for Ethics Committee in 2020 and 2021. She also as a member for Association of Diabetes Nurse Educators of the Philippines, Association of Diabetes Educators, Diabetes Philippines member, Philippines Society of Education Research and Evaluations, and Philippines Nursing Research Society. Next, please. And for her trainings that she attended, for example, completed on online training on flexible online learning from various institutions, including Centro, Escolar University, and also she completed outcomes-based education trainings and workshops on diabetes mellitus, and also for diabetes educator and diabetes conventional map. Next. Okay, without further ado, I would like to welcome our speaker, Ms. Jolene Lamado Mejilan. So the time is yours. So as the same speaker, the first one, you are going to have 30 minutes for presentations and 10 minutes for question and answer.
Okay. Thank you so much, Miss Rita.
You are very welcome.
Nama saya Joy, saya bersal Pilipina. Salamat pagi.
Selamat pagi.
Already salamat siang.
It's still morning, so
still morning. Salamat pagi. Magandang
Selamat
umaga to all. Okay, I am very delighted to be here in your international seminar on COVID-19 with comorbidities. And thank you so much, Health Poltekkes Jakarta 3, Ministry of Health Republic of Indonesia, for inviting me and able to share my knowledge about COVID-19 and its comorbidities. Happy International Nurses Week. Okay. So to begin with, this will be my learning outcomes. No? For 30 minutes, I would like to discuss with our participants overview of COVID-19, okay, clinical spectrum of SARS-CoV-2, and risk factors for severe illness. I am glad that Ms. Kanan actually discussed already the many risk factors for severe illness of COVID-19. I'll be focusing on the therapeutic management of adults for COVID-19 based on disease severity and care of critically ill adult patients. Okay, for the information of our participants, okay, my discussion will be based from the National Institute of Health, okay, recently updated, year 2022, and discuss the prevention and complications, okay, in hospitalized and critically ill patients with COVID-19 based on WHO 2020. And I would like to focus on the fundamental nursing care in patients with SARS-CoV-2 virus, okay? Because I would like to promote, okay, our very critical role, in the management of COVID-19 as a nurse. Okay? Okay, so just an overview, no, we all know that COVID-19 started in China way back in December 2019. And as of April 15, 2022, more than 503 million cases of COVID-19 already, no, in the entire world, and more than 6.2 million deaths. Okay, and then the probability of serious COVID-19 disease, okay, is higher in people aged 60 years old, more than 60 years old, and living in a nursing home or long-term care facility, and those with chronic medical conditions. But by the way, individuals of all ages are at risk for SARS-CoV-2 infection and severe disease. Okay, Ms. Kanan gave actually a very good overview of COVID-19. No, so I just would like to emphasize that 14% no of COVID patients will require hospitalization. Others will be admitted in an intensive care unit, and 5% will die no because of COVID. No, and then please take note also no that the number of patients who died in COVID no okay, was actually 12 times higher those with reported medical conditions. And Ms. Kanan already mentioned like diabetes mellitus, hypertension, pulmonary disorders, HIV, cancer, and a lot medical conditions no, that can cause COVID patients no, to die to have high mortality rate as compared to other people without medical conditions. Okay? And also the percentage of patients who were hospitalized was 6 times higher among those with reported medical conditions. So in short, okay, my dear participants, no, patients with medical conditions or comorbidity, okay, has a higher percentage of being admitted to the hospital and also with high mortality. Okay, so this is the clinical spectrum of SARS-CoV-2 infection. Okay, in my discussion, I will be focusing on the critical illness. Okay, and critical illness is actually those individuals who have respiratory failure, septic shock, and or other multiple organ dysfunctions. Okay, so since my topic will be more on discussing the therapeutic management of patients who was hospitalized or who is hospitalized no, with comorbidity. Okay. Okay, so critically ill patients may have acute respiratory distress syndrome, okay, it's called septic shock, and they may represent various induced distributed shock. Okay, so this distributed shock will actually can cause no end organ failure no because of the lack of supply of oxygenated blood to the different tissues no of the body. It may also cause cardiac dysfunction. And please take note that COVID-19 patients no, would have an exaggerated inflammatory response, no? Meaning there will be a higher amount of inflammatory chemical mediators or cytokines that will be produced that can cause organ failure to patients with critical case of COVID-19. Although COVID-19 is actually a pulmonary disease, emerging data suggests that it also leads to cardiac, dermatologic, hematologic, hepatic, neurologic, renal, and other complications. But in my discussions, I will be focusing in some management of your thromboembolic events. No, that is actually very common to patients with COVID-19. Okay, so blood clot formation is very common among patients with COVID-19 patients. Okay, so risk factors were actually discussed already by Ms. Kanan, no? So I would just like to summarize them again, no, for our students to remember. So increasing age, no, more than 65 years or older. Okay, and basically this age group has 97 times rate no of dying, okay, compared to aged 18 to 29. Okay, and there are a lot of medical conditions that are actually increases the risk of mortality, no, to patient with severe COVID-19 cases. Okay, so when we say it increases the risk of COVID-19, okay, these people with comorbidity will more likely to be hospitalized, will need intensive care, will require a ventilator to help them breathe. Okay, and again, sad to say, and very unfortunately, no, the rate of mortality or dying with COVID-19 is very high, no, with people with medical conditions. Okay, so again, these COVID-19, these medical conditions are high among patients with cardiovascular disease, with diabetes, no, and and chronic lung disease. Okay, again, I mentioned also cancer, kidney disease, liver disease, obesity, okay, sickle cell disease, and other immunocompromising agents. Transplant recipients and pregnant people are also at higher risk of severe COVID-19. Okay, so this is actually a report from China, okay, also specifying that the case fatality rate is higher than those with those people with diabetes, chronic respiratory disease, and cancer. Okay, so before I begin with the therapeutic management of COVID-19 in the hospital, I would like to review the two main processes thought to drive the pathogenesis of COVID-19. Okay, so early in the clinical course, the disease is primarily driven by the replication of SARS-CoV-2. Okay, but later in the course of the disease, okay, this disease appears to be driven by dysregulated immune or inflammatory response, meaning there will be production of very high inflammatory cytokines, okay, which can cause organ failure, no, to those patients with severe or critical COVID-19. Okay, and this may lead to tissue damage and thrombosis. And that is why venous thromboembolism is very common, or blood clotting problem is common among patients with severe or critical COVID-19. Okay, so remember this, no? Early in the clinical course, no, the problem is the multiplication or rapid replications of SARS-CoV-2, and later is the abnormalities in the immune response or inflammatory response of patients with COVID-19. Okay. And based on this pathogenesis, no, we have to remember that the first management of patient with COVID-19 should directly target SARS-CoV-2. Okay, so effectively, the greatest effect early is in the course of the disease. So we need to target SARS-CoV-2, okay, to prevent its multiplication, okay, in the patient. Okay, while in the latter part of the disease, the immunosuppressive or anti-inflammatory therapies are more beneficial, okay, to COVID-19, and this will very important when the patient reach the stage wherein the level of oxygen is very low or the patient has hypoxemia already. Okay, so as I begin to share with you the treatment, the therapeutic management of adults hospitalized for COVID-19 based on disease severity, again, I would like to reiterate that my reference for this discussion will come from the National Institute of Health, which was updated February 24, 2022. Okay, so as you can see here, this is the disease severity of the patient. Okay, and then the recommended antiviral or immunomodulator therapy. Okay, and then the recommendations for anticoagulation therapy. So as we can see in this therapeutic management, it is very well emphasized the use of medications like antiviral or immunosuppressant, okay, to address the two main problem of COVID-19, okay, and that is the multiplication of the virus and the dysregulated immune response or inflammatory response of the patient, plus okay, our problem in the thrombosis or the venous thrombus embolism, the clotting problem. Okay, so I would like to share to you, you will be noticing letters, okay, and some legends, in the illustration later, okay. So this is the rating of recommendations based from the NIH, okay, the National Institute for Health, A means strong, recommendation, B means moderate recommendation, C means weak rating of evidence, and the other legends would mean that they came from randomized trials, okay, and non-randomized trials, and other from expert opinion. Okay, you don't need to memorize this. I'm just trying to share with you that there are levels or rating of recommendations provided by NIH. Okay. To begin with, I will not be actually discussing in detail these medications, because I want to focus on the nursing aspect of taking care of patients with COVID-19 with comorbidity in the hospital. Okay, but as you can see here, the disease severity is these are patients who are hospitalized but do not require supplemental oxygen. Okay, so for this patient, the panel recommend against the use of dexamethasone, because in the different studies, no survival benefit for dexamethasone was observed among the patients during this disease severity. Those patients who does not require supplemental oxygen. Okay, and to prevent clotting problems or thromboembolism, prophylactic dose of heparin is needed, and we all know that heparin is actually an anticoagulant. Okay, and the prophylactic dose of heparin is actually administered for the duration of hospital stay. Okay, what about those patients hospitalized and that will require supplemental oxygen? So here we could see the use of remdesivir. Okay, it is a nucleoside analog, okay, used to inhibit the action of RNA polymerase. So your remdesivir will actually target the multiplication of the COVID-19 virus. Plus, again, this time around, dexamethasone plus remdesivir, okay, or monotherapy of dexamethasone, okay, are recommended for patient requiring supplemental oxygen. Okay, and again, as you can see here, heparin, maybe therapeutic dose or prophylactic dose, okay, are recommended. Okay, for hospitalized and require oxygen through high flow device or non-invasive ventilation. Okay, so what is a high flow device? Your high flow device is actually a heated and humidified system that allows a prescribed fraction of supplied oxygen. Okay, this is actually a way of delivering precise oxygen to the patient. And when we say non-invasive ventilation, okay, this is actually the patient will use a face mask, okay, and therefore will limit the use of will eliminate the use of the endotracheal airway. And they recommend also the use of dexamethasone plus remdesivir, okay, and again prophylactic use of your heparin. Okay. For the hospitalized and requires mechanical ventilation or ECMO, ECMO, your ECMO is actually your extracorporeal membrane oxygenation. This is actually a function of a heart and lung outside the body. This is the highest level of support that can be provided to patients who are requiring hospitalization and in critical stage. Okay, so in ECMO or ECMO, the blood is being pumped outside of the body to a heart and lung machine, and that removes carbon dioxide, and and the blood that will be returning to the body is now rich with oxygen, no, and that will help to oxygenate the tissues of the body. Okay. So actually, as you can see here, the tocilizumab is being added, no, in the regimen, and tocilizumab is actually an anti-inflammatory medications that inhibit inflammatory response, no, by inhibiting your interleukin-6 receptor. Okay, so your tocilizumab is actually an interleukin-6 receptor inhibitor. Okay, what about your again, your prophylactic dose of heparin, is also recommended, no, for this kind of patient. Okay, so to summarize the therapeutic management from NIH, you could see that the administration of medications, no, whether dexamethasone, no, or your remdesivir or your tocilizumab plus your heparin, okay, will depend on the severity of the patient. Now, let's proceed with thromboembolic events, no, and COVID-19. Okay, so again, as I mentioned a while ago, okay, the thromboembolic event is very apparent, no. We have a high incidence of venous thromboembolic disease in this population. Okay, so usually common example of your venous thromboembolic is your deep vein thrombosis in the leg, and which will may cause, no, your pulmonary embolism. Okay, so please take note, no, routine surveillance of ICU patients for venous thromboembolism is warranted. Okay, so we need to monitor possible, no, signs and symptoms of thromboembolism, like for example, no, patient may experience leg swelling or leg pain, no, and then when you touch the skin of the patient, the skin is warm to touch. Okay, and for pulmonary embolism, of course, you would notice that the patient will have unexplained shortness of breath, okay, and rapid breathing, and patient may complain of chest pain. And when you check the heart rate, it is very fast, okay, and sometimes, no, the patient may have lightheadedness, or patient may pass out or lost consciousness, no, because of their pulmonary embolism. Again, as mentioned, low molecular weight heparin like your enoxaparin will be administered to the patient, or your unfractionated heparin is preferred over oral anticoagulants. Okay, so for patient, no, for hemodynamics, no, the panel recommends the use of the usual assessment that we do, our dear nurses, no, we assess the temperature of the skin, no, we check the capillary refill time, okay, and then we check on the lactate levels over static parameter to assess fluid responsiveness. Okay, so when we say we prefer, no, we need to assess for fluid responsiveness. Okay, so this could include, of course, no, mga dynamic parameters that may include your stroke volume variation, your pulse pressure variation, your stroke volume, okay, or even, no, we can also measure the very common to all of us, the central venous pressure or the mean arterial pressure. Okay, and crystalloids, using buffered balanced crystalloids, which is actually your lactated rangers, as an example, is preferred over your unbalanced crystalloids. Okay, unbalanced crystalloid is actually your 0.9 sodium chloride. So what is preferred is actually your balanced solutions, which include your ringer solutions, no, over your 0.9 sodium chloride. And norepinephrine, okay, as the first line of vasopressor is recommended. Okay. So what about oxygenation and ventilation? As I've mentioned, okay, the panel recommends to patient with hypoxemic respiratory failure to use your high flow nasal cannula, okay, over your non-invasive ventilation. Okay, the reason for this is actually okay to prevent the transmission of COVID-19 viruses or virus in the environment. Very important to remember, okay, that we need to be precaution to prevent environmental contamination by SARS-CoV-2. Okay, so again, I think you all know what is trial of awake prone positioning. The recommendation is that panel recommends awake prone positioning for adults with persistent hypoxemia, okay, who require high flow nasal, okay, cannula, and for whom endotracheal intubation is not indicated. So meaning to say, awake prone positioning is indicated to those person who needs okay, high flow nasal cannula oxygenation and does not require intubation. Okay, and if intubation will be done, it is recommended that it should be performed by experienced practitioner in a controlled setting. Okay, and that is preventing the risk of exposure to COVID-19 virus. Okay, additional considerations for awake prone positioning. Again, the patient can adjust their position independently, okay, and can tolerate lying prone. Okay, again, please remember, awake proning should not be used as a substitute for intubation and mechanical ventilation. Okay, and also awake proning is not suitable for patients with problems in the spine. Okay, also those patients with fracture in the face or pelvis, and those patients with open chest or unstable chest wall. Okay, and it should be used very carefully to patients who are experiencing confusion, delirium, okay, or inability to change position, and who has recent abdominal surgery and problems with nausea and vomiting. Okay, now let's go to patient with acute kidney injury. So what is the recommendation by our NIH? Okay, basically, the same indications for RRT in patients with COVID-19 as those used for other critically ill patients. Okay, so for COVID-19, who are critical, okay, the recommendations is to for continuous renal replacement therapy. Okay, so what is continuous renal replacement therapy? Okay, this is actually a dialysis also, but the difference is that in continuous dialysis, it runs for 24 hours a day and increasingly used in intensive care units with acute kidney failure. Okay, it is more gentler on the body, and the 24 hours a day dialysis is actually administered very slowly, and it will continuously clean out the waste product and fluid from the patient. Okay, so when you compare it to regular dialysis, a regular dialysis will take about 3 to 4 hours, but your continuous renal replacement is actually again being run on a 24 hours a day. Okay, if CRRT is not available, the panel recommends prolonged intermittent renal replacement therapy rather than intermittent hemodialysis. Okay, so the reason for this, of course, is again, okay, to prevent the transmission of COVID virus, okay, in the environment. Okay. What about those patients who will require your ECMO? Again, your ECMO is your extracorporeal membrane oxygenation. As I've said, this is a short-time rescue therapy for patients with acute respiratory distress syndrome. Okay, and actually, the recommendation is there is insufficient evidence okay, whether to recommend for or against the use of extracorporeal oxygenation, no, to patients with COVID-19 and refractory hypoxemia. But based on the literature, no, many patients who are in the critical stage of COVID-19, okay, can be provided, no, with the ECMO, no, the extracorporeal membrane oxygenation. Okay.
Miss
Again,
Melida, we would like to remind you that you have 5 minutes left for the
okay.
presentation.
Thank you so much, Miss
Rita.
Rita. Thank you. Okay, terima kasih kembali. Okay. Okay, so again, with the pharmacologic interventions, no, remember that we have to be careful in the use of the empiric broad spectrum antimicrobial. Okay, this is to minimize the adverse effect of unnecessary antimicrobial therapy. But as you can see, there are a lot of patients, no, with bacterial infections like pneumonia who are being provided with antimicrobial therapy. Okay, again, as nurses, no, we have to monitor for drug-to-drug interactions, okay, specifically of patients with comorbidity. Okay, so many patients with comorbidity will be receiving or taking, no, drugs, no, intended for their disorder, no, like for patients with diabetes, and we have to monitor its interaction to other medications being administered to treat COVID-19. Okay, so again, this is all about, okay, this one is for cancer. Okay, again, as recommendation in treating patients with cancer, please take note, they are the same as those for general population. But as I mentioned, watch out for drug-to-drug interactions, and there is a need to consult with hematologists or oncologists before adjusting cancer-directed medication. Okay. With HIV people also, the same recommendation, no? The treatment or management is the same as those for general population. And again, continue their antiretroviral treatment and consult HIV specialists before adjusting or switching antiretroviral medications. Okay, so it's very important to pay attention to drug-to-drug interaction and avoid toxicities. Okay, so for other related complications like nosocomial infections, like ventilator-associated pneumonia and hospital-acquired pneumonia, okay, what is recommended is need to minimize the risk of conventional ICU complications, okay, to make sure that the outcome of the management is successful. Okay, other complications like infection should be prevented. Okay. To summarize, the management for patients with COVID-19 and to reduce the complications, okay, these are the anticipated outcome, So as much as possible, we reduce the days of putting the patients in mechanical ventilation, okay, reduce ventilator-associated pneumonia, okay, reduce also incident of catheter-related bloodstream infection, reduce pressure ulcer, okay, and reduce GI bleeding and stress ulcer. Okay, this before I end, I would like to give some time discussing, okay, the nursing management, of patients, okay, with COVID-19. Let us focus on our nursing care, and we could see here that the physical, okay, relational aspect and the psychosocial aspect of care, okay, are very important, in providing care to patients with COVID-19 in the hospital. And as you can see here in the physical aspect of care, okay, these are to be given emphasis, providing hygiene, okay, support in eating and drinking, okay, providing adequate rest and sleep, and allowing the patient to move, okay, in the bed or as much as possible. If the patient is ambulatory, okay, with assistance, then they can actually move, okay, move or walk around the bed, okay, and providing comfort and safety is very important, okay. For relational, I think we should remember that we need to still establish okay, a very good relationship with our patient by talking and listening, okay, and touching them as a means of nonverbal communication is very important. It's also very important to communicate with our patients if they are able to, and specifically to patients' relatives or carers, no, for that particular matter. And remember, nurses, no, providing dignity and respect, respecting patients' values and beliefs, okay? And well-being of our patient are also very important. So again, please remember this care area, okay? This is a study done in United Kingdom, and these are the nursing care that most nurses responded, no, that they are providing to patients with COVID-19. Okay, to end, okay, so again, there is limited information to suggest that critical care management of patients with COVID-19 should differ substantially from the management of other critically ill patients, meaning, okay, patients with comorbidity, okay, will receive similar, okay, management, no, of other critically ill patients, and special precautions to prevent environmental contamination by SARS-CoV-2 are warranted, and successful management of patients with COVID-19, okay, will initially result in less number of ICU admission, okay, and less number of nosocomial complications or infections. And lastly, okay, healthcare providers should monitor such patient closely until clinical recovery is achieved, and effective nursing care, okay, is to meet the patient's fundamental, okay, need are physical, relational, and psychosocial needs, okay, are very important, okay, and I think is also a challenge to all of us nurses. Okay, so these are my references, and thank you for your kind attention. Terima kasih banyak. Okay, maraming salamat.
Thank you so much for Ms. Mejila for this presentation. That's really informative how we're dealing with patients with comorbid, that we do not deal only for the physical, but also the psychologists. So that's really important to make them recover quickly and as soon as possible. So now we are going to have question and answer sessions. So the committee will share the screen, and we have several questions already from the participants. There are 3 questions that we have seen in here. The first one in from Rizka Erlina, Poltekkes Kemenkes Jakarta 3. And her question is, of course, this COVID disease is dangerous, especially if sufferer has comorbids. The question is this condition afflict elderly patient and has chronic kidney disease? Will the treatment to be the same? Or is there any treatment for that one?
Okay.
So we can,
Yeah, I can answer already, Ms. Rita.
Yeah, you can answer the first question, please.
Okay, so actually, as I mentioned, no, in my discussion, no, according to the recommendation, the management of COVID-19 patient with comorbidity are actually similar with other critically ill patients. Okay, but on top of that, of course, no, from the basic or advanced management of COVID-19 patients, okay, the comorbidity or the medical conditions like diabetes, hypertension, cancer, HIV should be managed as well, okay, together with the management of COVID-19 patients. Yes, it's very difficult to manage, no, a patient with comorbidity, okay, because it is not only that you need to treat the COVID-19 virus and the abnormal inflammatory response because of the COVID-19 infection, but you have to manage as well, okay, the condition of patient, right? For example, for diabetes patient, no, the rising glucose level, okay, you should be able to manage that. Okay, also the rising the blood pressure of patients should be managed, okay, and a lot more. Okay, like for example, in cases of patient with DM, okay, remember in the therapeutic management, the patient will receive dexamethasone, which is actually a glucocorticoids or corticosteroids, and this medication alone increases glucose level, no, of the patient. So if you have a patient with COVID-19 and with diabetes mellitus, you have to really focus on, okay, glycemic control, because the therapeutic management itself of COVID-19 with the use of your dexamethasone increases also your your glucose level. Okay? So it's difficult. I agree with you, Miss Rizka.
So we have to really pay attention about the medicine that we are going to give to the patient and also the comorbid that they have right now. So we have the second question from Nunung. She's also from Poltekkes Kemenkes Jakarta 3. So the question is, if complications occur in inpatients and critical ill patients, what kind of nursing care should be done?
Wow, that's a very good question, Nonong Bagus. Okay? I like the question. Tepuk tangan. Okay? Because no, I am a nurse. Okay? Actually, I'm more comfortable answering questions related to nursing. Okay? So, as I mentioned in my last slide, no, Nunong, okay, our nursing responsibility or care should focus first, of course, physical need of our patient. Okay, like nutrition, okay, rest and sleep, mobility, hygiene, okay? These are basic and essential needs of our patient. But of course, in a patient in a critical care unit or ICU, okay, aside from this usual nursing care, of course, you need to make sure that the ventilation and oxygenation of the patient is adequate, no? Because as we all know, patients with COVID-19 who are in severe stage would experience hypoxemia or a decreased level of oxygenation in the blood. So I think our priority nursing care here is on ventilation and oxygenation. And of course, may I add Nuno, okay, very important to prevent nosocomial infections, no, or other infections that may be associated with, okay, COVID-19 infections, like as I mentioned, no, infections from the use of prolonged catheterization, okay, prolonged intubation and hooking the patient in a mechanical ventilation that can lead also to pneumonia. So these are very important nursing care, Nunong. But again, as I mentioned, please always include relational, okay, and psychological support to our patient. Remember, patients in ICU, they are alone, no? And the emotional, okay, and the psychological impact of being alone, okay, and plus having COVID-19, plus the comorbidity will be very, very stressful to the patient. So be there with the patient, no? Talk with them, listen to them, and touch them. Thank you, Nuno.
Thank you so much. That's really wonderful answer for especially for the patient in ICU that
Yes.
nobody, no family, no friends, only the healthcare
Yes.
providers in the room.
Very terrible experience, I would say. If you are a patient in ICU and you are alone, and diba, Miss Rita, no, contact of nurses are actually limited because of course, no, as a recommendation, no, short contact with the patient with COVID is warranted, no, to prevent the transmission of diseases. So even as nurses would like really to be with them in a longer period of time, we cannot do that. And then since we have so many patients, we could not stay so long also with one patient only.
Yes, it is really true. So we have limitation to contact with the patient. We also limited time because of a lot of patients in the room. Now we are going to have the last questions. It's from Yulia Putri from Poltekkes Kemenkes Jakarta 3. And the question is, what are the differences in nursing care actions, such as what is done for COVID-19 patient with comorbidities and without comorbidities?
Oh, thank you, Miss Yulia, for the question. I think there is no actually difference in the nursing care, no, to patient with comorbidities and without comorbidities. basically they are the same. But again, I would like to emphasize that, okay, aside from COVID nursing care, okay, you need to also include nursing care specific to their disorder. Like, for example, if a patient has renal failure or acute kidney injury, okay, then you have to add more nursing care focusing on their fluid and electrolyte balance, like weighing them, making sure that the patient is limiting adequate intake of fluid and monitoring their electrolytes, guiding them or supervising them to have their hemodialysis, okay, as ordered. So, but basically, Ms. Julia, no, as mentioned by our NIH and WHO, the management or nursing care will be similar with or without comorbidity. Thank you for the question, Ms. Julia.
Thank you very much, Ms. Mejila, for answering all these questions. And it's really makes us understand about how to deal with patient with comorbid for COVID-19 patient. So before we ended this session, I would like to read the conclusion that based on the NIH recommendation, the level of treatment for the patient COVID-19, and then the patient with COVID-19, they have problem with coagulation, oxygen, hemodynamics. So that's why we have to give them treatment, including giving oxygen, dexamethasone, and also like anticoagulation. However, in giving this treatment, we also have to pay attention because there is can be increase the glucose of the patient if they get dexamethasone. So we have to deal with not only the COVID-19 virus, but also the other condition of the patient. And for the treatment, we should not only focus on physical situation, but we also need to focus on relationship and psychosocial of the patient. And now, before we end this one, I would like to give the opportunity for the head of Diploma 3 School of Nursing, Ibu Santun Setiawati, to hand the certificate for Miss Joylin Lamado Mejila, MANRN. For Miss Santun Setiawati, please.
Yeah. Thank you, Mrs. Rita. For Miss Joy, thanks for your time to be speaker in webinar Internasional, and we will give you a certificate from Director Poltekkes Kemenkes Jakarta 3, and we hope we will join in the other moment. Thank you very much, Mrs. Joy, for your speaker in here.
Sama-sama.
Selamat siang ya di sana. Thank you, Miss Rita.
Okay, thank you, Miss Santun Setiawati. And again, thank you very much for Miss Joylin Lamado Melida. And I will say also in Philippines language, salamat, salamat, salamat. I hope it's correct.
Yeah, it's correct. Walang
thank
anuman. Welcome.
Oh,
Okay, happy, Miss Rita. And congratulations to this wonderful international seminar.
Okay,
Thank you so much, Miss Joylin, and the faculty member of Central Escolar, Erjon, and 2 students that already joined this webinar. Thank you.
Yes, thank you, Miss Paula. Happy to see your beautiful face.
Thank you so much.
Thank you.
So thank you.
See you again in the next seminar. So this is the end of the first session, and I would like to say thank you to the all speaker, Mrs. Tanale Kumikanen, and also Miss Joylin Lamado Meljila, who have shared all the information about how to deal with the patient with comorbid on COVID-19 patient. And I would like also to congratulate to the committee for our student who already conduct this wonderful and really informative seminar about COVID-19. And also now I would like to return the season 2 Master of Ceremony Salwa Putri Afifa and Jessica Meliani Sinaga. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you, Bu Rita.
Ya, sama-sama. You're very welcome, Miss Paula Krisanti.
Thanks and appreciation to Mr. Rita Ismail, Bachelor of Nursing, Master of Public Health, MCDHE, PhD, for guiding first and second session. Also to the first speaker, Ms. Tanale Chumikanan, and second speaker, Mistress Joelyn Lamadonijila, who has shared knowledge and experiences that are very useful to us. The next is symbolic awarding of certificate to the moderator, Mistress Rita Ismail, which will be delivered by Head of Nursing Diploma 3 Study Program of Health Polytechnic of Ministry of Health Jakarta 3, Mistress Santun Setiawati, Master of Nursing, Bachelor of Nursing Pediatric Nursing Specialist. To Mistress Santun Setiawati, the time is yours.
Ya, terima kasih untuk MC yang sudah dengan luar biasa ya memandu acara ini. Untuk moderator Ibu Rita yang sangat expert ya untuk bahasa Inggrisnya, oke banget ya.
Terima kasih.
Sudah memandu acara ini dengan sangat baik ya. Terima kasih untuk nanti kegiatan selanjutnya bisa ikut terus gabung ya Bu Rita.
Siap, Ibu. Insyaallah. Baik, terima kasih Bu Santun untuk sertifikatnya dan untuk panitia, selamat ya. Semoga lancar terus untuk acaranya hingga pembicara yang ketiga. Saya undur diri, terima kasih.
Terima kasih Bu Rita, terima kasih MC.
Terima kasih banyak Bu Rita.
Sama-sama Bu Indri.
Thank you, Mr. Santun Setiawati, for delivering your certificate.
Ladies and gentlemen, next we enter to the event of the third session. We'll present the third speaker from Indonesia, the delivery of all material question and answer session, with the speaker will be guided by Ms. Meviana Arahman. She is a student of the Department of Nursing Health Polytechnic of Ministry of Health Jakarta 3. Here is her curriculum vitae. All right. Her full name is Meviana Arahman. She was born in Jakarta, 27 May 2002, and this is her contact number, 0812-127-62552. And her email is mevianaarahman72@gmail.com. And she lives at Masjid Istiqomah Street, West Cengkareng District, West Jakarta. Let's take a look at her educational history. From 2010 until 2015, she graduated from Wanyadika Elementary School. Then from 2016 until 2018, she graduated from 248 Jakarta Junior High School. And from 2017 until 2019, she graduated from 84 Jakarta Senior High School, and now from 2020, she continued her education in Health Polytechnic Ministry of Health Jakarta 3 and majoring in nursing. Ms. Meviana Arahman also has some organization experiences, but the last one is becoming the head of Nursing Student Association of Health Polytechnic of Ministry of Health Jakarta 3 in 2020. Let's take a look at the list of awards that Meviana Arahman got, but the newest award is first rank writing essay in the National Health Polytechnic English Olympic in 2022. All right, to Ms. Mefiana Arahman, you might guide this session.
Okay, thank you very much for the MC. Assalamualaikum warahmatullahi wabarakatuh, ladies and gentlemen. Welcome to our third session with me, Mefiana Rahman, and I will be serving as your moderator for this session. Now you'll be hearing a presentation from Mrs. Nurse Patriani, Bachelors of Nursing from Indonesia for about 30 minutes, and after that we will have a discussion session for about 10 minutes. But before we get started, I would like to take a few minutes of your time to know more about our speaker. Okay, so her name is Mrs. Patriani as Nurse. She was born in Pitala on September 17, 1974. And now she lives in Cipinang Baru Raya Street in East Jakarta. And a little bit about her. She is a head nurse of the emergency department in National Central General Hospital Cipto Mangunkusumo in Jakarta. Next. Okay, so for her education history, at 1993, she graduated at SPK Cipto Mangunkusumo High School, and then she managed to get a diploma in 2003 from Health Poltekkes Jakarta 3. And in 2009, she also took high school again in science program. And in 2011 and 12, she received a bachelor's and professional degree at the Faculty of Nursing at the University of Indonesia. Okay, now we're moving along to our session. Please welcome Mrs. Patriani, who will be speaking to us on regulation and identification, the application of emergency installation triage in the era of the COVID-19 pandemic. Without any further ado, let's meet our fabulous speaker. Hello, Mrs. Patriani.
Hello. Good evening,
Hello.
Mefiana.
Yeah, good evening. Okay, for Mrs. Patriani, you will present your presentation for about 30 minutes, and then we will have a discussion session for about 10 minutes. Okay,
Okay.
for Mrs. Patriani, the stage is yours.
Okay, thank you. Okay, thank you. Good evening. Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.
Thank you for all best wishes for all of us. Thank you for Poltekkes Kemenkes Jakarta 3 for inviting me to share experience about how to organize the triage process during the COVID-19 pandemic that we have experienced in recent years. Introduce my name, Fatriani. Please call me Unifat. Yeah. I work in emergency room at the Cipto Mangunkusumo Hospital. Please allow me to explain about the triage system implemented is in the hospital emergency room during the pandemic COVID-19. Sorry. Yes.
Problem.
Slide-nya bisa di slide share nggak?
Sebentar. Hilang. This.
Do you have any problem, Miss?
Yes.
Okay, do you want the commit to help you for the
Okay.
share screen?
Okay. Yes.
Okay.
Thank you. Okay. Next slide. Next slide. Yeah. Please look at the these two picture. This and next picture. The emergency room situation is very crowded, and the emergency room situation where there are no patients. Next slide. Yeah. Of course, this situation is always visible, and because ER services are dynamic and unpredictable. Next slide. For that, we need a system to manage a situation in the emergency room, starting from receive patient by triage officers, so that the flow of patient arrive and going from the emergency room can be controlled. Triage is the process of assessing and grouping patients based on their level of urgency. The level of urgency is determined based on the patient clinical condition at the time of triage. Yeah, we call re-triage. Next slide. Yeah. The triage location in the emergency room hospital in front of entrance to the emergency room. Before the pandemic era, the triage officer was after the emergency room entrance, like this. During the pandemic, the triage officer shift out of the emergency room entrance, because the triage officer for non-COVID-19 cases was the same as the COVID-19 triage officer. Next slide. Yeah. Intra-hospital triage goals ensure the level and quality of service in accordance with the clinical criteria of the patient, optimizing the safety and efficiency of emergency room services. Ensure equal access to health service for the entire population, facilitating an improvement of the quality of emergency services, KPI, key performance indicators, time to treatment according to the triage category. Next slide. There are 4 triage scale used in the world. Is a guideline for implement the triage system in hospital emergency room. This is MTS, Manchester Triage Scale, and ESI, Emergency Severity Index, and Australia Trauma Scale, next Canada trias acquisition scale. The scale contains assessment indicators used when trias is sorting outpatient in emergency room based on the severity of the patient. Next slide. Next slide. Yeah. The fourth trias scale states that there are 5 levels or 5 categories of patient based on their condition when they arrive at the emergency room. This is ESI, level 1, level 2, 3, 4, 5 level, and MTS, color red, orange, yellow, green, and blue, and then CTAS, resuscitation, emergency, urgency, less urgency, and non-urgency. And then ATS, category 1, 2, 3, 4, 5. This is same as 5 level, 5 category, 5 color. Next slide. Yeah. Evidence-based practice, 5 level trials has better reliability and indicators than 3 level trials. MTS, ESI, ATS, and CTAS widely adopted by other countries. Adoption important of indicators. 3 level trials has good validity and reliability on low volume emergency room patient. Public health care of emergency type C or D hospital, like that. Next slide. Although there are several other factors that affect the application of the 5 level and 3 level trial scale to determine whether it is appropriate or not in accordance with the type of emergency room service area. Yeah, trials effective and efficient. Trials officer must trials component. There are 4 things that make a trial system effective and efficient. Usability, easy to understand and applicable. Valid, be able to measure the level of urgency based on the patient clinical condition. And then reliable, this is consistency or similarity of trials result when trials is repeat. Safe, decision on the level of urgency through trials must be in accordance with the clinical criteria of the patient and can achieve optimal outcome. Next slide. Next slide. Next slide. Yeah. Trials component. 4 component of hospital trials. Humanist interaction, decision making, patient flow, and initial treatment. Trials component decision making is very important of trials because the treatment or management of the patient condition depends on trials decision related to the patient level of urgency. Next slide. Yeah, trials officer must have several abilities and skill in trials, such as cognitive, trials experience, critical thinking, and intuition. Trials officers must be able to analyze and then decide on the level of emergency of the patient according to the condition when he arrived at trias. Determine the step to treat the patient. This is problem identification and data analysis, evaluation, decision, action priority, and monitoring, evaluation. Clinical nurse 3 about qualification trias nurse, and nurse emergency must behave to training of trias. Next slide, Meviana. Next slide. Yeah. Oh, revise slide, revise material I sent to Tina. Yeah. Wait me. A parameter of AWS screening COVID-19. Next slide. Yeah. Parameters of sign of pneumonia with lung CT scan and history of close contact with confirmed COVID-19 patient and fever, age, gender, maximum temperature, symptom of respiratory distress, and neutrophil to lymphocyte ratio. Next slide. This is triage algorithm. Triage algorithm, the patient arrive at the ER. Please you look this. The condition is assessed by primary triage, whether there is a history of ARI or not. After that, it is a short into the ARI category or not. If the indication is ARI, the patient is placed in the ARI or COVID-19 room. If there is no ARI case, the patient is placed in a non-ARI area or non-COVID-19 area. Secondary triage, next slide. Next slide. Yeah. Next slide. Secondary triage examine patient with an indication of ARI or COVID-19 based on the level of urgency and the level of virulence of the patient. Secondary. Next, monitoring patient according to the clinical pathway for COVID-19 patient in emergency room. Next slide. Triage. Triage is process to sort, distribute based on severity. The meaning of the word triage come from the French language is sorting or sort. In medical, triage is a system that allows the determination of priorities for the care and transportation of patients to save as many lives as possible. Next slide. Yeah, this is disaster triage pandemic COVID-19. Prevent COVID-19 patient overload in the hospital, secondary disaster, cross-contamination, health worker exposure. And point 2, prevention contamination of all health facilities in the outbreak area, hospital zonation, COVID-19 and non-COVID-19 services. Point 3, achieve response time. Point 4, reduce case fatality rate. Next slide. Activity of COVID-19 disaster triage, mapping distribution COVID-19 patient in hospitals at the outbreak area, and mapping hospital level, human resources and facility, and detect any overload potency in appropriate hospital level. And point 4, distribute and redistribution COVID-19 patient based on severity level matching with hospital level. And 5, hospital zonation for prevent contamination to non-COVID-19 hospital. And point 9, referral communication system between hospital. This is emergency nursing, team method according to the number and severity of patient. And next slide. And very dynamic, changing all the time, work area according to competencies level, clinical nurse and clinical authority. Teamwork is very important. All team members work for the same goal. Coordination line refers to institutional policy. And this the flow patient in emergency room services apply at 5 level triage, at the level triage, starting from the time the patient arrived at the emergency room and is received by primary triage, secondary triage, as previously explained about sorting ARI and non-ARI patient. Then followed by secondary triage, then management according to the clinical condition of the patient, whether it is internal medicine, surgery, neurology, children, and others cases. Then assess and decide whether the patient needs hospitalization, surgery, or can be outpatient. This is apply triage scale 5 level. Next slide. Yeah. This is the flow of patient when the Cipto Mangunkusumo Hospital service has implemented 3 level of triage in recent years, starting from the time the patient arrived at the emergency room, received by triage, no more primary and secondary, to save human resources and short patient waiting time, so that patient can be treated more efficiently, fast. After the patient enters the zone, red zone, yellow zone, and green zone, or COVID-19 zone, the next treatment is the same as in the patient flow, with the application of 5 level triage, whether the patient require hospitalization, surgery, or can be outpatient. Next slide. Implementation of quality and safety standard, very important in emergency room, regulating the flow of entry and exit of employee and student, that must be a concern of the emergency management. Compliance with the use of PPE, using and remove PPE at the appropriate location, and compliant with the implementation of hand hygiene for emergency room from all of discipline. And the clean lines of the surfaces is always maintained, compliant with the rule in the surfaces area must be under the monitoring of the security team, and providing education on the risk of falling by using a yellow clip on the risk of falling. And this slide 7S trias process that must be known and applied by trias officer. Next slide. See through, say hello, soft touch, specific question and examination, syndrome interpretation, life-saving management, and send to zone. Next slide. See through, look from the far, evaluation the person, the affect, and the sound. And from general inspection, we can have some information about general appearance and we look lethargy, pain, unconscious, anxiety, distress, and seizure, and gait to the patient, body composition, thin, obese, malnourished, and pregnant, facial appearance, pale, jaundice, and asymmetric, and any obvious wound, hemorrhage, or deformity. Next slide. Say hello. If you trias nurse, trias is the first impression for patient before enter the emergency room. Good first.
Miss,
Yeah.
I would like to remind you that you have 5 minutes left.
Yeah.
Thank you.
Good first impression will have other emergency room staff when dealing with the patient. Good first impression will reduce risk of compliance, and quality interaction means that in a specific announce of time, trias can be obtained specific information and also give comfortable and respectable interaction. Next slide. Say hello. Next slide. Proactive come to the patient car, introduce yourself calmly, reassurance, and respected and confidence body language, and educate patient and family what are our interpretation of the patient condition and what would we do. Next slide. Soft touch. At trias counter, we have limited time to examine a patient and make a razor sharp decision, so that best thing that trias can do check patient pulse. Checking the pulse, rate, volume, regularity, and distal extremity temperature, warm or cold, and capillary refill time. During pulse examination, we can also observe patient airway, any stridor on gargling sound, and evaluate patient breathing. Next slide. Soft touch, additional simple examination can be done according to patient chief compliance or region of trauma. Evaluation of conscious level using AFPU and simple check part of the body that previously got injury. Next slide. And consciousness assessment, A, AFPU, alert, be able to activity submit compliance. Verbal, respond to only when called. Pain, respond only to painful stimuli. And unresponsive, no respond at all. Next slide. Specific question, simple and limited question at the front line to help trials prioritize the patient condition, chief compliance, and associate symptom, maximum 3 questions, and then comorbid. Next slide. Pain assessment, mild pain, moderate pain, and severe pain. Next slide. And syndrome interpretation suggest diagnosis. First, think about the most life-threatening condition. If we cannot make fine decision from primary trials, try to gain additional information from secondary trials. Next slide. Life-saving management. All activity to help patient condition at trials. Put patient on trolley of or wheelchair. Have evacuate patient from car, elevate patient head, and loosen the clothes, pressure bandage, and cervical collar. Next slide. And next, send to zone. Razor sharp decision must be have reason. Resuscitation zone is a place for patient warm, life-threatening, and need immediate intervention. Next slide. Conclusion, qualification and competencies of nurses conducting trials are very important. Experience, understanding of indicators, data collection, analysis, and decision-making skill. Trials training is recommended to focus on decision-making process, cases, and supervising or shadowing. The role of trials nurse in the initiation of trauma team activation in trauma cases is very important. Emergency, daily trials, and trials when MCI or disaster occurs have different focus. The best trial system is one that is easy to understand, applicable, valid, reliable, and can achieve optimal patient outcome. Next slide. And trials during the COVID-19 pandemic must include an initial assessment of the patient virulence level using COVID-19 screening EWS. The WS COVID-19 screening doesn't replace the daily trials that has been carried out in the emergency room. It only adds an element of vigilance to the trials process. An effective pandemic trials process can prevent transmission of the virus that cause COVID-19 to the patient and health worker. Next slide. Yeah. And then please the finish I presentation about trials system and apply trials nurse can be pandemic COVID-19. Please you question to me. I will answer to your question. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for Mrs. Unifa, right? It was very insightful and we can learn so much from you. Now we know that about the application of the triage system in the emergency room in COVID-19 era, and you also told us about the process and the components of the triage system and also other assessment. Okay, now it's time for the audience to give their questions to our speaker here for Mrs. Sunifa. There are 10 minutes for a discussion session. And same as before, for those who want to ask, you can put and fill your questions to the link that is already shared by the commit. Okay, in the screen right now, we already have the first question from Alda Mesha from Health Poltekkes Jakarta 3. The question is there a difference in triage before and after COVID-19? And if so, please explain.
Yeah, thank you. Thank you, Alda. The trials before and after pandemic, before, during, and after pandemic era, pandemic COVID-19. The first, the trials location, before pandemic COVID-19, trials location in entrance emergency room, and during pandemic COVID-19, trials location in front of emergency room, like that. And assessment to the patient. My slide. If you can share my slide.
All right, wait a minute.
Yeah, triage algorithm. Triage algorithm. Triage algorithm. Yeah. The patient arrived before pandemic COVID-19, and the patient the same area. If the patient arrived to triage location, put the patient the same area, cannot different. During pandemic COVID-19, the patient arrived at the ER. The condition is assessed by primary triage, whether there is a history of ARI or not. After that is short into the ARI category or not. If the indication is ARI, the patient is placed in the COVID-19 room or ARI room, isolation room. We call isolation room. If there is no ARI cases, the patient is placed in non-ARI area. As assessment of the patient specific to the respiration, about compliance to the patient, like that cough or sputum and fever. Can you share my slide? Next slide. About triage, assessment of primary triage and assessment of secondary triage. About EWS screening COVID-19. Yeah, Alda, different of assessment of before pandemic COVID-19 and after pandemic COVID-19, like that. We do assessment and put the patient at the different area, like that. Enough, Alda?
Thank you very much for Mrs. Ofani. So the difference before and after COVID-19 is the location and the algorithm, like the assessment.
Yeah.
So I hope, Alda, I hope you can understand now after the explanation from Mrs. Patriani. Okay, we're moving along to the next question. Okay, for the next question here is from Fanny Suri from Health Polytechnic Jakarta 3. In PowerPoint, it is explained that in triage patients with COVID-19 are required to use personal protective equipment level 2, whether it only applies to patients with COVID-19 or for all patients in the emergency room.
Yeah.
Yeah.
About, sorry, the question.
Okay.
Share the question.
I said the question is about the protector APD.
Yeah.
APD. Yeah.
Protocol of PPE during pandemic COVID-19 recent years, there is a few of different about PPE APD. Now, protocol PPE protocol, we use APD level 2. So important, we use N95 mask, N95 mask, N95 mask. About the patient chief compliance in respiratory condition, we don't use APD level 3. It in COVID-19 patient room, we use APD level 2. Yeah, very important to for use mask N95 mask. Just it. No cover all, no gown. We use scrub like that. Okay.
Okay, thank you very much for Mrs. Patriani. For Miss Fanny, I hope you can understand after the explanation from Mrs. Patriani. Okay, maybe for the comment, can you share screen again for the questions? Okay, maybe I would like to ask Miss Fatriani. I would like to know, is there any obstacles or you already experienced after COVID-19 in the preparation or the implementation of the triage system in the COVID-19 era? Are there any obstacle or maybe some experience that you have after you prepare the implementation of the triage system in the COVID-19 era? Apakah ada hambatan atau dalam persiapan atau pelaksanaan sistem triage ini?
Ya, jika boleh saya boleh paparkan 2 slide tadi dengan bahasa Indonesia. Yang tadi alur, yang 2, yang 5 dengan yang 3.
Alright, you can. Maybe for the commit, you can share screen the presentation from Mrs. Patriani.
Ya. Slide sebelumnya, slide setelahnya, yang alur. Sorry, Meviana. Ya. Mohon izin, Madam Ola. Saya butuh untuk 2 slide ini saya paparkan kepada teman-teman terutama Poltekkes Jakarta 3 terkait dengan perbedaan bagaimana kami menyelenggarakan triase 5 level dengan 3 level bila kita hubungkan dengan kondisi pandemi. Mohon izin. Ini alur pelayanan ruang gawat darurat yang menggunakan 5 level tadi. MTS, ATS, ESI, dan CTAS. Pada triase 5 level, teman-teman dapat memahami setelah nanti saya sampaikan, apakah kita akan menerapkan triase 5 level atau 3 level. Mengingat, melihat, menimbang kemajemukan pasien dan kemajemukan kasus yang diterima di area pelayanan kita. Tentu tidak bisa disamakan apakah harus 5 atau harus 3. Tetapi nanti saya paparkan sedikit, teman-teman bisa memilih atau membedakan apa sih bedanya yang 5 dengan yang 3. Sebelum pandemi COVID-19, kami menerapkan 5 level ini di tahun 2016 sampai 2017 pertengahan. Ini sebelum pandemi. Nah, triase 5 level sebetulnya terdapat triase primer, triase sekunder, perbedaannya sangat terlihat di sini. Tetapi pada banyak jurnal yang saya baca akhirnya, karena memang tesis saya yang lalu adalah terkait dengan ketepatan triase, tapi saya hubungkan lagi dengan kode trauma, yaitu trauma multiple, di mana efektif dan efisiennya triase 5 level dengan 3 level sehubungan dengan melihat ketepatan triasenya. Triase 5 level ini ada yang namanya triase primer dan sekunder. Disinilah mungkin sedikit kekurangan kita ketika di area pelayanan itu sumber daya manusia tidak berlebih atau tidak cukup. Dalam arti terbatas, kalau triasenya 5 level, ada primer, ada sekunder, sementara primer itu perawat, sekunder itu adalah dokter umum, sementara tata laksana awal tidak bisa dilakukan oleh triase sekunder ini. Padahal triase sekunder ini adalah medis, general physician. Nah, tata laksana awal dilakukan oleh Integrated Multidisiplin Emergency Team. Dalam hal ini IMED. Kami menyebutnya IMED. Ini merujuk kepada banyak jurnal yang dihasilkan dari UK dan dari beberapa negara yang menerapkan memang triase 5 level. Nah, kemudian setelah diterapkan oleh tata laksana awal oleh tim IMED ini pun terbagi lagi 2, trauma dan non-trauma. Nah, sehingga ketika kita menerapkan triase 5 level, pasien merasakan respon time kita memanjang. Karena memang diawali oleh primary triage, kemudian secondary triage, kemudian baru pasien mendapatkan tanda laksana awal oleh tim trauma dan non-trauma tadi. Setelah itu baru pasien ditransfer apakah posisinya adalah red zone, yellow zone, atau green zone. Atau bahkan isolation room, seperti itu. Nah, boleh slide selanjutnya? Kemudian masuk kepada era pandemi, kalau tadi kita menerapkan yang 5 level, maka seperti dikatakan oleh algoritma triase yang 5 level tadi, dipilah dulu apakah ini kategorinya ISPA atau non-ISPA, kemudian dipisahkan tempat penerimaan di triasenya, sementara di kami triasenya hanya 1. Setelah dipilah ini ada indikasi ISPA atau tidak ISPA, baru pasiennya masuk ke ruang isolasi, dilanjutkan proses triasenya di ruang isolasi untuk ditentukan apakah kategori triasenya itu merah, kuning, atau hijau. Tetapi kami sudah menerapkan triase yang 3 level ini, yang hanya ada primary triage, tidak lagi ada secondary triage. Nah, apa keberuntungannya dari 3 level? Tata laksana awal atau initial treatment tadi dilakukan oleh general physician tadi, yang pada triase 5 level general physician tadi hanya sebagai verifikator. Dia hanya memvalidasi apakah triasenya sudah betul atau belum. Demikian. Jadi penerapan triase 3 level ini merujuk juga kepada Kemenkes 2016 yang diperbaharui pada 2018. Sampai saat ini untuk kasus COVID dan non-COVID, kami menerapkan triase yang 3 level. Seperti itu. Kalau mau melihat perbedaan yang tadi teman-teman tanyakan, apa perbedaan triase sebelum dan setelah pandemi? Tentu jelas, sangat jelas. Sebelumnya kita tidak menggunakan AP, hanya bahkan kita jarang juga menggunakan surgical mask. Tetapi pada era pandemi tentu saja teman-teman yang berada di triase sampai saat ini menggunakan APD level 2. Dilengkapi dengan gaun, kemudian masker N95, dilapisi dengan surgical mask, dan sangat disarankan untuk penggunaan face shield. Karena apa? Karena penerimaan pasien yang COVID dan non-COVID tadi berada di satu area triase. Demikian. Nah, kemudian masuk ke ruang isolasi, teman-teman di ruang isolasi pun menggunakan APD-nya level 2, yang paling penting adalah masker N95 dan dilapisi dengan surgical mask yang diganti setiap 4 jam. Jadi dalam satu shift ketika pagi, sore, dan malam, teman-teman dibekali oleh 2 surgical mask dan 1 N95 yang bukan berarti ketika terjadi satu kondisi khusus terkait dengan APD tersebut, teman-teman harus mengganti. Mengganti dalam arti minta yang baru, kemudian pakaikan. Seperti itu. Mungkin itu tambahan penjelasannya, Meviana, untuk 2 slide ini. Terima kasih.
Okay, the moderator, I would like to translate to English. So, from the explanation from Unif 3, that the different for the accepting patient on the ER in Cipto Mangunkusumo Hospital before the pandemic is using the 5 level to patient that enter the ER room, and the lack of this level is make the patient to wait more longer to have a treatment. But after the pandemic, they use the 3 level of they implement the 3 level of a system to accept the patient, and the difference is we know that before, if the treatment is based on the primary and secondary initial assessment, but after the pandemic, they straight to the primary initial treatment. So that's make the patient is not waiting more longer to have a treatment. And the other difference is when accepting patient already differentiate with the whether the patient is already have the altered function in a respiratory system or not. Then that's they starting from there. Maybe I can make resume like that. Thank you.
Thank you, Madam Ola.
Thank you very much for Mrs. Fatriani and also to Ma'am Paula as your explanation for the question that already asked by our audience and our participant. And unfortunately, the time for the discussion is already done. And before I end it, I'm going to conclude that we need the triage system with the 7S process and 4 components, so we could make a decisions and give quality service to the patient in emergency room. And also for the additional in this COVID-19 era is we have the 3 level of the triage system. Okay, next is the handover of the certificate by Mrs. Indriana Rahmawati, Bachelor of Nursing, Master of Science, MTDHE, to our speaker, Mrs. Fatriani. For Mrs. Indriana, the time is yours.
Oke, thank you, Mevi. Assalamualaikum warahmatullahi wabarakatuh, Mbak Fatriani.
Salam.
Mudah-mudahan sehat ya, alhamdulillah.
Ya, terima kasih Bu Indri.
Ya, she is one of our alumnus from Diplomatry ya, dari mulai Diplomatry ya Mbak Fatriani ya.
Iya, betul Bu.
Diplomatry and she continue. Mudah-mudahan cepat jadi dokter ya. I hope someday you will be doctor of nursing, Mbak Fatriani. Amin, insyaallah. Maka atas nama ya Ibu Direktur, karena pada kesempatan yang sama ini beliau sedang ada tugas lain yang tidak bisa diwakilkan, saya menyampaikan penghargaan kami yang tertinggi untuk Mbak Fatriani, sertifikat kegiatan seminar internasional ini sebagai salah satu speaker. As one of the speaker in this international certificate, I will be delivered the certificate, and we thank you for your sharing knowledge. This is very operational, I think, and this is a benefit for our students. And my highest appreciation for your presentation, Mbak Fatriani, and participation for this seminar. Hopefully, we can do something like this in the further occasion ya. Yang ke depan masih bisa bersedia membantu lagi ketika kami memang membutuhkan hal-hal yang sifatnya kemajuan dan sifatnya adalah operasional di lahan. Sekali lagi, terima kasih Mbak Fatriani. Thank you for your attention. Give our regards to all the staff in RSCM. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Bu Indri.
Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for Mrs. Indriana, and thank you very much to Mrs. Fatriani for being the presenter for today's seminar and for your great and amazing presentation. And also thank you for the audience for the great question. If you have additional question for maybe for Mrs. Fatriani, you can connect with her, maybe with or through a private message or a private meeting. Okay, that's all for me. I hope you can enjoy the rest of the event. Thank you very much. I bring it back to the MC. Thank you.
Okay. Thanks and
Thank you for all. Thank you, Miss Ola, and all the committee.
Thank you so much
for conduct this international seminar ya. Sukses
Thank you,
for all.
Unifat. Thank you, Mevi, and all committee.
Thank you, ma'am.
Okay. Thanks and appreciation to Ms. Meviana Arahman for guiding the third session, and also thanks to Ms. Fatriani, who has shared knowledge and experiences that is very useful to us. The next is symbolic awarding of a certificate to the moderator, which will be delivered by the Secretary of Nursing Department of Health Poltekkes of Ministry of Health Jakarta 3, represented by Ms. Indriana Rahmawati, Bachelor of Nursing, Master of Science, Master of Technology Development and Health Environment. The time is yours.
Okay, thank you for the master ceremony to Mevi. So we give you the certificate for your competence for as moderator. I think this is very good. And hopefully for the next occasion or next event, you can join as a speaker. Right, Mevi? So you have to upgrade, not just moderator. And success for you and all the committees. Thanks again.
Thank you very much, ma'am.
Iya, sukses ya.
Thank you to Mrs. Indriana Rahmawati, Bachelor of Nursing, Master of Science, Master of Technology Development, Health Environment. All right, ladies and gentlemen, this is the end of the main event of the speaker's presentation, but participants are expected not to leave the Zoom meeting because at the end of the event, there will be a games and door prize announcement to lucky participants. Before the games and door prize announcement, we invite our sponsors today, Ines Cosmetics, to present the material.
Baik, terima kasih atas kesempatannya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat siang semua, selamat siang untuk seluruh panitia. Kami ucapkan terima kasih banyak. Senang sekali kami dari Ines Kosmetik dapat mengikuti acara pada siang hari ini. Perkenalkan, saya Astri yang hadir pada hari ini sebagai perwakilan dari PT Kosmetika Tama Super Indah atau biasa yang disebut dengan Ines Kosmetik. Salam kenal, kami dari Ines Kosmetik. Next. Tahukah Anda sebesar 82,5% wanita Indonesia beranggapan bahwa cantik berarti memiliki kulit yang cerah dan glowing. Next. Tagline kami yaitu Happiness with Ines membuat wanita Indonesia memperoleh kebahagiaan dengan kulit yang cantik sehingga menyebarkan energi positif kepada orang-orang di sekelilingnya. Next. Ines Kosmetik merupakan sebuah brand kosmetik yang sudah memiliki ratusan produk meliputi makeup, skincare, dan body care. Next. Dan Ines Kosmetik juga sudah memiliki sertifikat halal dan sudah terdaftar di BPOM sehingga tidak perlu diragukan lagi untuk keamanan dan kehalalannya. Dan Ines memiliki produk yaitu Peel Off Mask dan juga Clay Mask yaitu yang diperkaya dengan oil absorber menyerap kelebihan minyak, deep pore cleansing untuk membersihkan kedalaman hingga ke pori-pori, cooling sensation yaitu sensasi dengan dingin pada kulit. Dan untuk kulit yang normal ada Peel Off Mask itu dengan kandungan moisturizing untuk melembabkan wajah serta deep pore cleansing membersihkan ke dalam pori-pori dan juga remove and deep skin cell yaitu mengangkat kotoran dan lapisan kulit mata. Next. Dan Ines Kosmetik dapat diperoleh melalui Shopee, Tokopedia, JD.ID, dan e-commerce lainnya, atau juga bisa melalui sosial media kami yaitu www.ines.co.id, Instagramnya Ines Kosmetik, Facebooknya Ines Kosmetik, atau juga bisa download di My Play Store yaitu Ines Kosmetik. Next. Dan khusus untuk acara pada hari ini ada diskon 30% untuk setiap pembelanjaan Deep Cleansing Clay Mask, Brush on Peel Off Mask yaitu diskon 30% dan diskon 15% untuk all varian produk Ines Kosmetik selain Deep Cleansing Clay Mask dan juga Brush on Peel Off Mask itu diskon 15% dengan cara men-screenshot voucher yang ada di layar dan bisa menghubungi kontak person yang ada di voucher yaitu di 0813 733782 agar bisa mendapatkan diskon tersebut pada acara hari ini. Dan setiap pembelanjaan free ongkir up to 20.000, minimal pembelanjaan Rp150.000. Next. Dan make up itu bukanlah topeng yang menutupi kecantikanmu, namun make up membantumu mengekspresikan siapa dirimu dari dalam. Baiklah Kak, terima kasih atas kesempatannya. Mohon maaf apabila ada kesalahan. Selamat mengikuti acara selanjutnya. Salam sukses. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you to Ines Cosmetics for presenting an interesting material. Ladies and gentlemen, now we enter the ice-breaking session. We will play games, namely guess the picture. The committee will provide several pictures and the winner is the one who can guess the pictures as soon as possible. The committee will choose 3 winners from games Guess the Picture. Here's the rule.
The ice-breaking rules. First, participant can raise hand when they want to answer the question. Second, participant will be given 10 seconds to think about the answer. Third, participant by raising their hand fastest and being able to answer the question will be the winner. Okay, the committee, maybe we can start the games. Okay, let's start the games. This is the first question. Guess the word. Okay, we count down from 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. Anybody can guess the word? Okay. For the participant, maybe you can unmute your microphone or you can text on the Zoom chat or YouTube comment column. Okay, let's see the answer. Let's see the answer. Okay, the answer is metabolism. So the lucky participant who raised hand fastest is Ruri Koirunisa. Congratulations. Okay, next question. Okay, participant can guess the picture, the word. So we count down from 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, stop. Okay, let's see the answer. The answer is recovery. Okay, so the fastest participant that raised hand is Pani Suri. Pani Suri, okay, congratulations. Okay. Okay, next question. There are 3 pictures. The participant can guess the word. We count down from 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Stop.
Let's see the answer.
Okay, let's see the answer. The answer is bladder. Okay, so the lucky participant is Cindy Putri. Congratulations, Cindy. Okay, the game has finished, guys. The committee is expected to give the name to the of the winner to the MC. Okay. Next, we will inform the door prize. The committee will choose 2 of name from participant at random as the door prize winner. So the lucky participant that win the door prize is Alda, Meisha, and Nunu. Okay. For selected name, there are Alda, Meisha, Nunu, Ruri, Panisuri, and Cindy Putri. Please contact the contact person in the list on the list. Or chat by Zoom chat or YouTube kolom comment. Congratulations to all the winners. Okay, ladies and gentlemen, participant of international seminar, before the event ends, we will do a documentation session. All participants of the online international seminar are expected to activate the camera.
Okay, please, for all participants are expected to activate the camera. Okay, starting from page 1. Then page 2. And the last is page 3. Thank you all.
Okay, thank you. We would like to kindly remind to all participants to fill in the final attendance form in the chat Zoom or YouTube comment column. And, and all the material from the speakers okay, and all the material from the speakers will be sent by the committee by Zoom chat or YouTube comment column. Okay, again, we would like to kindly remind to all the participants to fill in the final attendance form in the chat Zoom or YouTube comment column or scan the barcode. Thank you for all the participants for joining in this event from the beginning to the end. We hope that the knowledge from our speaker today can be useful for all of us. We generally apologize for there might be any mistakes or lags. We hope that we could meet in the next international seminar.
We, Sawa and
Jessica Melanie, as the Master of Ceremony
of this seminar, checking out. Thank you for your attention. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Good afternoon. See you on the next event. Thank you all.
Selamat ya untuk panitia. Untuk daftar hadirnya sepertinya tidak bisa diisi. Coba dicek lagi ya.
Iya, nggak bisa tuh. Lama semuanya. Tolong format daftar hadirnya. Tidak bisa dibuka.
Mohon izin Ibu, untuk link presentasi akhirnya sudah dapat diisi Ibu.
Ya, udah bisa dibuka. Terima kasih.
Baik Ibu, terima kasih.
When everyone disappears somewhere, but but you always keep to protect them. And your sacrifice without a sound for the love of another smile. When everyone is asleep soundly, but you're still awake for all the time, and forget the tired of your life for the love of another soul. The world has smiled because of you, knowing you and trust your life for them, no matter what you have now in your life, for the love of another soul. You are a hero for the world, and God will give all the best to you, for all the priceless very in your life, for the love of another soul. And even though there might be no place, even place for you to sign my parade, but I always pray the best. Always pray the best for you. This voice is all to you. The world has smiled because of you, knowing you and trust your life for them, no matter what you have now in your life, for the love of another soul. You are a hero for the world, and God will give all the best to you, for all the priceless very in your life, for the love of another soul. For the priceless very in your life, for the love of another soul. Na 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 na. Ooh. When everyone disappears somewhere, but you always keep to protect them, and your sacrifice without a sound for the love of another smile. When everyone is asleep soundly, but you're still awake for all the time, and forget the tired of your life for the love of another soul. The world has smiled because of you, knowing you and trust your life for them, no matter what you have now in your life, for the love of another soul. You are a hero for